Hello and welcome to another pathology lesson. In our lessons, we'll be looking at pathology of the abdominal organs and how they are viewed on ultrasound. Today's lesson is the first in a 5-part series regarding liver pathology. Let's go ahead and get started then on diffuse disease. We'll first start with fatty infiltration, and you will see as we move through each of the pathologies that we will be covering the definition of the disease. We'll be talking about the incidence rate, who's more likely to get it, what the clinical signs and symptoms are, some of the treatments and prognosis of the disease, and then finally take a look at how these diseases appear on ultrasound. So fatty infiltration is defined as the reversible disease that results in fat accumulation in the hepatocytes. So the hepatocytes, remember, are the liver cells, are the functional part of the liver, and there's already maybe a little bit of fat in there. But with fatty infiltration, that fat accumulation becomes very abundant. And when we have too much fat within our cells, it makes the cell not work as well. So fatty infiltration can affect how the liver operates. Now, fatty infiltration is also known as steatosis. So here's a nice picture showing this nice healthy liver on the left side of our screen. It's nice red, full of blood and doing its job. Comparing that to the one on the right, it's all yellow. We kind of associate that kind of yellow coloring with fat globules, and that's a diseased liver, a liver that's not going to be working as well because of that fatty infiltration. Microscopically, we can see the same thing. Normal liver on the left, again, the cell walls are all outlined in pink. The nuclei are the purple dots in the middle. We can see that they are very dense, very little extra material within the cells. Compare that then to the liver on the right, both showing excessive fat buildup within the cells, and we can see that in those larger white spaces. Now, fatty infiltration does come in a couple variants. The first variant being focal fatty infiltration. And with focal fatty infiltration, we see that as islands of fat within normal liver tissue. So you have a very normal liver for the most part. You're just going to have these little sections, these little islands that are going to be overrun with fat. Oftentimes they follow along with the Coinad's anatomy, with the division part of it. So you'll see a little island of fatty tissue. There's also focal fatty sparing then. This is where the whole liver is mostly fatty infiltration, and then you have these little areas that don't have focal fatty infiltration. So we call that the spared area, or the focal fatty sparing. Typically, focal fatty sparing is seen around the gallbladder. For the most part, when I see it on ultrasound, I don't necessarily measure it, but I do take pictures of it, maybe with an arrow pointing at it, just to show the radiologist that I saw it, and then they can determine. I still take pictures of it with and without color in long and transverse images. I just don't necessarily measure it, especially if it looks like focal fatty sparing versus some sort of mass in the area. So who gets fatty infiltration? These are mostly likely going to be obese patients and those who abuse alcohol, drink excessively. Now, there's tons of other reasons why a person can get fatty infiltration. The two that you need to know, obesity and alcohol abuse, are going to be the big ones. But we do also see it then with patients with high cholesterol, diabetes, steroid use. TPN is getting nutrients through an IV for those who are very, very sick and can't eat by mouth. Pregnancy can bring it on. Hepatitis, that's inflammation of the liver. Cystic fibrosis, glycogen storage disease, taking certain drugs, or having chronic illnesses, all can cause a person to have fatty infiltration. So we can see that fatty infiltration is caused by a lot of different diseases. It makes sense that we're probably going to see this quite often in the population. Clinically, these patients are typically going to be asymptomatic. Very rarely does a patient come in and be like, oh, my liver, it feels so fat. Like, it just doesn't happen. Often what happens is that they're going to have some blood work done. The blood work comes back a little abnormal, and they get an ultrasound done because of it, and lo and behold, we see fatty infiltration. Now, if their fatty infiltration is advanced enough, or has moved to a different category of fatty infiltration, we might start to see a little bit more symptoms pop up. And that can include jaundice. Again, that kind of comes back to the liver not functioning very well, nausea and vomiting, and then maybe a little bit of abdomen pain. With fatty infiltration, what I typically see on the abdomen pain, they kind of describe it as like this dull ache up on the right side. Like it's just kind of uncomfortable up there. So as I mentioned, lab tests usually do come back slightly abnormal in these patients. What I think I see most commonly doing ultrasounds is a patient goes in for their yearly physical. They don't really have any symptoms of anything. They get their lab work done just because that's what they're doing. And those come back slightly elevated. And the doctor's like, well, there's nothing really else major going on. Let's just take a look with ultrasound. Easy peasy, lemon squeezy. They come in and they have that fatty infiltration. So if you see slightly increased LFTs or maybe some increase in bilirubin with no other real symptoms, more often than not, you're probably going to see fatty infiltration on the ultrasound. As far as treatment and prognosis, it's really important to note that fatty infiltration can be reversed. The hepatocytes are really awesome and they are able to heal themselves. The liver is able to regenerate and heal itself. And so if the person changes their lifestyle, stops drinking, becomes more healthful in the food choices that they make, start losing weight, there's a really good chance that they will reverse the fatty infiltration. So it's good to know that we can reverse this, because on one scan, maybe a year ago, they had fatty infiltration and you're not seeing it this year. Maybe it's because they stopped the drugs that they were taking. They're not pregnant anymore. Fix their cholesterol. Any sort of lifestyle change can help this patient with their initial diagnosis. Now there's going to be some key terms that we're going to talk about as we move through some of the diseases. And fatty infiltration, a key term for this one is NAFLD or NASH. The NAFLD stands for non-alcoholic fatty liver disease. And we're going to contrast that then to NASH, which is non-alcoholic steatohepatitis. Now, NAFLD is the most common reason for liver disease in America. It makes sense with our propensity to obesity in America, to alcohol use, to all the other things that we like to do in America. Kind of makes sense that we're going to see a lot of this non-alcoholic fatty liver disease. If a patient does not take care of themselves in the NAFLD stage, it can progress then to NASH, where we get non-alcoholic steatohepatitis. Now, not only do we have fatty infiltration at that point, we add on the hepatitis part, which is then inflammation of the liver. So we have a fatty, inflamed liver. NASH, untreated, can then further progress into cirrhosis, which then can further progress into some liver cancers. So NAFLD, very common, reversible. Stop doing what you're doing, or multiple things that we can do to reverse that. NASH can also be reversed. Once it progresses to cirrhosis, though, that's the point of no return. And here we have a nice image showing us just that. So we start with a healthy liver, and as the fat cells are in there, totally normal, totally fine. But as we progress to NAFLD, we see that there's more fat cells within the hepatocytes. The cells stop working nearly as well. And then that can progress again further to this NASH, where we start to then see inflamed cells, very large deposits of fat. We start to see some collagen fibers coming in. That's because the liver is healing itself. It makes fibrotic strands through itself. And once we get to this point, we're on the fence. Can we fix this or not? If the patient changes their lifestyle well enough, they could probably actually undo a lot of the damage, maybe not all of it, but a lot of it. The problem is if they still continue on the same course, we're going to progress to cirrhosis. And when we get to cirrhosis, we have dead cells, we have lots of scarring, lots of fibrotic tissue, lots of inflammation, a liver that is just very, very sick. So what does fatty infiltration look like on ultrasound? First and foremost, the liver is going to be very echogenic. The liver is also going to appear what we say dense. It's going to have increased attenuation, and then we'll see that we don't see the walls of the vasculature very well. So let's take a look at what some of these look like on ultrasound then. So in this first picture here, we have a picture of the fatty infiltration. We can see that we have the liver here. It's very echogenic compared to what we expect. But what I really want to point out is look how much attenuation we have down at this far field. We are starting to lose a lot of that information in the far field, and that's very typical of fatty infiltration. So attenuation is actually one of our key terms. This is a throwback to physics, and it's a key sign of fatty liver. So remember that attenuation happens when sound has to travel through tissue that causes the sound beam to weaken. As that sound beam weakens, it cannot send back nearly as strong of echoes, and so what we find is that our picture gets darker or weaker as the depth increases in the picture. And so in the case of the fatty liver, we end up having a very fatty liver, very dense, absorbs a lot of that ultrasound energy, and then we find that that far field gets a lot darker because we just don't have as much sound energy getting to that area. What I do want to point out though too, with attenuation and fatty liver, it's easy just to take a picture and be like, look, fatty liver, I guess I'm going to move on. But the problem is that it's still your job to take a look through that area you can't see very well. So you need to know how to adjust your machine, how to optimize your physics to still see that area. Even though you can't see it very well initially, your job is to take a look at all of that liver tissue. So you need to roll the patient, try different windows, turn harmonics off, increase your gain in that far field, try different frequencies. You need to see all of the liver tissue. Here's another example then of some fatty infiltration. We can see that we have a very echogenic liver. We always like to compare the echogenicity of the liver to the echogenicity of the kidney. So we like to compare that interface. Typically the liver is much more in line with what the renal parenchyma is. This much of a difference also helps to indicate fatty infiltration. Again, here is a very bright echogenic liver. Comparing that to the right kidney, this is a fatty liver. Compare that then to this normal liver on this side, we've got the liver parenchyma compared to the kidney. These are much more relative to one another compared to the fatty liver. So this is a very hallmark sign of fatty liver, seeing that very echogenic liver compared to the right kidney. When we talk about density of the liver, sometimes their liver is so dense because of all the fat accumulation that we can hardly even see the right kidney. And we can kind of see that here. We're starting to lose a lot of the borders, a lot of the definition of the kidney compared to our normal liver side where we can see that fairly well. We talked about focal fatty infiltration as being a variant of fatty infiltration. So here we have an image of the liver. We have really normal liver tissue surrounding, but what we can see in here is just this kind of stripey of really bright echogenic liver parenchyma. So we are documenting this as focal fatty infiltration. It's an island of fat within the liver. Now it's important that we do take pictures of this. Maybe I would probably measure it, put some color on it, because we can't know for sure, is this some sort of abnormal tumor versus fatty infiltration. So we still want to make sure that we are working it up in the same way that we would any pathology. Compare that then to focal fatty sparing. We have a relatively echogenic, dense liver. Near the gallbladder, we're finding this kind of irregular shaped, normal looking area. And this is that focal fatty sparing. This area has been spared of fatty infiltration. So as I had said earlier, typically I just put arrows to these spots, especially in the setting of fatty infiltration near the gallbladder. We're most likely going to assume it's focal fatty sparing. I don't typically measure these, mostly because measured items need to be followed up, where this is a very benign finding. They're not going to want to follow this up in 6 months. But I still go through long and trans pictures of this with color just to show the radiologist that I saw it, and if they have a different idea on it, if they do want it followed up, then there's images of it and it can be measured on the PACS system. Hepatitis is our next disease that we'll talk about here. Again, we're always going to start with the definition of the diseases. We have the definition of hepatitis, if we just look at the breakdown of the word hepa, liver, itis, inflammation. So we know that this is an inflammation of the hepatocytes. And when a patient has hepatitis, it causes damage to those hepatocytes. Now we know again that the liver can heal itself, the hepatocytes can regenerate. So there is a way to come back from hepatitis. There is reversible healing that can happen. But we might find that there are some long-term issues that occur from the initial hepatitis. Many diseases then also come in an acute and chronic form. In the case of hepatitis, we consider acute hepatitis to be a hepatitis that lasts less than 4 months, where chronic hepatitis is going to be hepatitis that lasts more than 6 months. 5 months is just kind of indeterminate. They'll probably lean it more towards chronic unless it resolves in that 5th month. So again, we have a nice healthy liver on the top there. In the case of hepatitis, the liver just kind of gets angry. If you've ever had a cut that's kind of got infected and you see that redness kind of pop up around it, that's what I always kind of think about. It's like an angry, red, hot, kind of enlarged appearing organ whenever there's an itis or an inflammation going on. Now, hepatitis actually comes in a lot of variants, and it's not really in the scope of ultrasound to diagnose any of these variants by ultrasound, but it is always good knowledge to have in your pocket. So we talk about probably viral hepatitis is the most common form of hepatitis, and even more so A, B, and C. Hepatitis A, B, and C are the most common forms of hepatitis that we will encounter in the ultrasound department. Now there's tons of other hepatitises. They're all defined by their letters. So D, E, and G are actually the next most common ones. You might see it, probably not. I have not seen D, E, or G personally, but I have had A, B, and C all on my table. Hepatitis can also be caused by toxic causes. So that can be alcohol, drugs, chemicals, or supplements. Remember when we talked about what the liver does, it's responsible for storing vitamins. And if you are taking way too many vitamins, it would make sense then that you can cause some damage to your liver. Drinking enough alcohol, that causes damage to the liver. Drugs like Tylenol are processed through the liver. So if you have too many of these toxic substances in your bloodstream that are then filtered by the liver or processed by the liver, it would make sense then that they can cause some inflammation if they are in excessive amounts. Lastly, then we have immune hepatitis. And autoimmune diseases are very common. In this event, autoimmune diseases typically cause the body to think that healthy cells are invaders, and then it attacks those healthy cells. When it attacks those healthy cells, then it causes damage to them. And so this can happen to the liver as well. And what we typically see in this case is some sort of concurrent infection. So we might see the herpes virus, mono, which is also known as Epstein-Barr, or the kissing disease. That can cause some hepatitis. Wilson's disease is a copper storage issue. So there's just too much copper being stored within the liver, which is irritating to the liver. We have hemochromatosis, which we're actually going to talk about a little bit more in detail, but this is too much iron within the liver. And then lastly, lupus, which is a systemic autoimmune disease, and it can cause the body to attack the liver cells as well. So here we have a microscopic example of the liver tissue. On the left-hand side, we have very normal plate here of liver cells, and then on the right-hand side, what they're showing is that there's just a lot more lymphocytes in the area kind of attacking those healthy liver cells. So this is an example of autoimmune hepatitis. So who is more likely to get hepatitis? If we look at just the viral cases, the viral hepatitis A, B, and C, hepatitis A is most likely transmitted via the fecal-oral route. So we see hepatitis A most likely transferred in like the restaurant setting. Maybe a food handler has hepatitis A, goes to the bathroom, doesn't wash their hands very well, comes back, handles the food, somebody eats it, they've passed along the hepatitis A. So that's the one that we probably see the most commonly through this route. Now, hepatitis B and C are more likely to be passed through bodily fluids. Hepatitis B has a vaccination for it. It's a 3-part vaccination. It is most commonly needed for health workers because of our exposure to bodily fluids. So that might be, handling dirty needles or handling other bodily fluids. If, somebody was infected with it and then you get it in your eye or in your mouth or something happens, then you can contract hepatitis B fairly easily in the healthcare setting if you are not vaccinated against it. Hepatitis C is also another very common viral hepatitis that is also spread by bodily fluids, but we see this more commonly in people who share needles, who possibly share razors through sexual intercourse, and of course on normal means that might happen in the hospital as well. Hepatitis C is not treatable. And what we're kind of seeing now, there's a lot of older Americans that have hepatitis C due to lifestyles from like the 70s, and now we're seeing them on our tables with this hepatitis and advanced stages of it. So it's actually probably my most common thing that I see are probably hepatitis B and C, just for follow-up livers. We scan them like every 6 months just to take a look at what their liver is doing. Some other causes of hepatitis, we talked about the toxic versions. If you're in a workplace where maybe you're inhaling lots of chemicals, that might be making you more prone to develop hepatitis. If you are abusing alcohol or drugs, that's going to make you more likely to get hepatitis. And then, of course, if you have any sort of systemic diseases like lupus or mono or herpes, anything like that, then that raises your chances as well. Clinically, these patients are going to come in with jaundice. So remember that jaundice is kind of a yellowing of the skin. It's because the bilirubin in the skin that's produced by the liver is not processed quite right. So it kind of leaches back into the blood, circulates around the body, and then it causes the skin to turn a little bit more yellow. We quite commonly see it in the sclera of the eye. Normally those are very white, almost like a blue tinge to them. They turn very yellow. You can see it underneath the tongue, and then of course on the body as well. These patients are often going to have nausea and vomiting, abdomen pain. As the hepatitis worsens, they're going to have more issues with fatigue and fever. And then lastly, dark urine is a very clear sign of hepatitis. Again, it comes back to the bilirubin not quite getting processed the right way. It ends up getting flushed out through our urine and makes the urine very dark. Lab tests that go along with hepatitis then are going to be increased LFTs for sure. The liver is not working very well, so we're going to have the AST, ALT, all of that is going to be very increased. We might also see then increased bilirubin. Again, the body's not processing it the right way, and so it leaches back into the blood. If the patient has blood tests for any of the viral hepatitis, those are most likely going to come back positive. They are antibody tests, so if you have antibodies for hepatitis B running around, then they suspect that you have had hepatitis B. They might also be positive for the toxins. Maybe they're positive for alcohol, positive for excessive vitamin B, whatever it is. They're also going to show toxins or diseases on positive lab tests. Treatment and prognosis for hepatitis then. Acute hepatitis is usually going to be treated with some sort of medication or changing the environment that the patient is in, stopping the alcohol, stopping the inhalation of chemicals at work, whatever that might be. So that's going to be your main treatment for acute hepatitis. Normally doesn't cause any issues. They recover just fine. Chronic hepatitis, on the other hand, though, can cause many more issues for a patient and actually carries many more risks for the patient as well. When we're looking at those hepatitis B, hepatitis C patients that have moved into the chronic side of things, those are the patients that we see every 6 months, every year. We're following the progression of the disease and what it looks like on their liver. They cannot cure it at this point, so we are just making sure that the liver still functions well, looks relatively normal, that there aren't any tumors or anything like that popping up, no ascites for the patient, all late stage risks of a damaged liver. Hepatitis C, then ends up being the most common cause for liver transplants. Usually, though, it has to be from a live donor because you can't get a liver transplant if you have some diseases just off of the universal donor list. It has to be a live donor relative gives you a little bit of their liver. Now, we're concerned about hepatitis C and that chronic infection because that chronic infection causes the liver to become damaged. And as it becomes damaged, it's going to try to heal itself. But as it tries to heal itself, there is going to be some changes to the liver. We start to see fibrosis. And if you think about getting a cut on your skin, you get a cut, you get a scar. And that scar usually is kind of like thicker skin, right? It's not normal skin. And that's the same thing that happens to the liver. It gets hurt, it tries to heal itself. It does a pretty good job of it, but it's just not quite right. And that's where we get those fibrotic strands. The fibrosis then can develop further into cirrhosis, which we'll talk about shortly here. But cirrhosis then causes the liver to not function very well at all, and then can even lead to cancer of the liver. So when a patient is diagnosed with hepatitis, most of them are going to get cured, not a big deal, moving on with life. There's a good chunk of them, though, that do move into that chronic inflammation of the liver. And if we don't get that chronic inflammation, that chronic hepatitis under control, they can start to progress to more serious cases. So what is the ultrasound appearance of hepatitis? In the initial stages of hepatitis, an early hepatitis, acute hepatitis, we're going to have mostly a normal-sized liver. It can progress, though, to being an enlarged or hypoechoic liver. So we can have normal. We can also have kind of a big, darker liver. In acute hepatitis, we see something called periportal cuffing, which gives us the starry night appearance. And I have pictures of these here in a second. Or we can have gallbladder wall thickening along with it, especially if there is fluid or ascites around the liver. That causes irritation to the gallbladder wall, which makes it a little bit thicker. So here is a picture of our acute hepatitis. This is the starry night appearance. Remember, starry night is due to periportal cuffing. And what we see in the acute hepatitis is very normal liver tissue. And then what we see around the portal veins are thicker walls. That's that periportal cuffing. The walls get a little bit thicker. They get a little bit more echogenic, and so we see these really bright spots throughout the liver along the portal triad. So it's my trick for remembering this. You're taking acute date out. Maybe you're going to go look at the stars at night. Chronic hepatitis then changes the appearance of the liver. At this point, the liver has been trying to heal itself, and there's going to be changes then to the appearance of the liver because it's just not healing itself like brand new. It's healing itself to try to function again. So what we see with chronic hepatitis is a very heterogeneous, kind of rough looking liver parenchyma. And we might start to see some changes in the shape of the liver as well. So as promised, we're moving on to cirrhosis. Remember, cirrhosis was a very late stage NASH appearance. It was a late stage hepatitis issue, and it can just be an issue on its own as well. So cirrhosis is a non-reversible cycle of damage and healing of the liver that's going to result in fibrotic nodules and death of the liver tissue. So we've kind of been talking about this all along, that fatty infiltration can be reversed. You just got to change what you're doing. Hepatitis can be reversed. It can heal itself. It'll be okay. If you have continued fatty infiltration, continued hepatitis, there is going to get to a point where the liver just can't really heal itself all that well. And that is cirrhosis. And so what happens is that the liver is damaged, those hepatocytes are damaged, it tries to heal itself. It does an okay job for a while, but like we talked about with the scars on the skin, we start to see some fibrotic changes. And those fibrotic bands that go through the liver as it's trying to heal itself actually really impact how the liver is going to function. And because of that, then it gets damaged again. Well, then it tries to heal itself again. And so it's a cyclic damage, healing, and eventually the healing just isn't as effective as it was. And so what we see then are these fibrotic nodules that pop up, or the hepatocytes just start to die. They're just not going to be able to come back from the disease process. So on the left-hand side here, we have our normal healthy liver. It looks very plush. It's juicy looking. You can see all the cells are very densely packed together, very healthy looking. Compare that then to our cirrhotic liver. You can see there's a bunch of little nodules on it. So those are our fibrotic nodules. You can see some areas here are a little bit darker. Those are probably more necrotic areas. And if we look at the microscopic version of it, we can see those fibrotic strands coming through, and you can see how they're kind of separating out these islands of, you can see how there's lots of deformity within the tissue. Compare that to the very homogeneous, very uniform appearance of the healthy one. The unhealthy cirrhotic liver just looks really gross looking, right? So this is a very damaged liver. This is a liver that's not functioning very well. There are a couple variants of cirrhosis in the way that it appears on the gross specimens. We can have micronodular cirrhosis, and this is going to be the result of alcohol abuse, or we can have macronodular cirrhosis, and this is typically the result of the progression of viral hepatitis. So micronodular is going to have tiny little fibrotic nodules within it. One way to remember micronodular goes with alcohol abuse. We talked about, or a class that I had earlier, we figured out that microbreweries are a thing and they produce alcohol. So that was a great way to remember micro goes along with alcohol. Macro on the other side then produces very large nodules. So here we have some images of the micronodular versus macronodular. You can see on the micronodular cirrhotic liver here, just tiny little fibrotic nodules kind of spread all over the place. Compare that then to the macronodular, we can see much larger nodules, islands of that fibrotic tissue developing on the liver. What I also want to point out in this picture too is if you look at the periphery of the liver on both of these, especially the macronodular one, you can really see how this is kind of like chewing away, very irregular. We can actually see that on ultrasound. That's one of our key diagnosis parts. So we can see how those fibrotic nodules can change the periphery or the lining of the liver. Now, who's more likely to get cirrhosis? Number one cause of cirrhosis is alcohol abuse. These are patients who, for their body, not everybody has the same level of alcohol abuse that causes cirrhosis, but for their body, they have consumed too much alcohol, too much in the day, too much over the years, whatever it may be, that has caused the liver to become cirrhotic and can no longer function. Now, the second most common cause is the viral hepatitis. We talked about how from going into the chronic stage, into the fibrotic stage, and then to the cirrhosis. So we know that viral hepatitis after the chronic stage poses a much higher risk of developing into cirrhosis. Now, we also know that there are some other diseases that cause fatty infiltration, which we know can develop into cirrhosis, such as Wilson disease or hemochromatosis. But then we also have some biliary pathologies, such as primary biliary cirrhosis and cholangitis, that can cause cirrhosis as well. So the two that you need to remember, alcohol abuse and viral hepatitis, and then just kind of logic your way through the fact that anything that causes fatty liver or anything that causes hepatitis can progress to cirrhosis as well. Clinically, these patients are going to be suffering from jaundice. They're most likely going to have some weight loss and fatigue that goes along with it. And the big one here is ascites. So yes, they are probably losing weight, but what they'll notice is that the girth of their abdomen is increasing because they are building up fluid within the peritoneum. So you'll have like these tiny little skinny arms, skinny legs, but then they'll have just this like big, almost pregnant appearing belly, especially in the late stages of cirrhosis. The other thing that we'll see too is hepatosplenomegaly, especially in kind of the beginning stages of cirrhosis. The hepatosplenomegaly occurs because blood is coming in from the spleen, coming in from the gut, and it's trying to get into the liver. And the liver is just kind of the stop wall that's like, I can't function, my cells are broken, I can't take in all this blood, I don't know what to do with it. And so it just kind of gets congested and starts to get large. Well, when that happens, all the blood backs up then, and it starts to back up into the spleen. And so then the spleen starts to get large because that has way too much blood in it. So in the early stages of cirrhosis, we'll find that the patient has hepatosplenomegaly. As the disease progresses, the body figures out ways to shunt that blood in other directions. So it'll create new vessels to get the blood out of the spleen or get the blood out of the liver. And so we do start to see is the liver starts to kind of shrink down where the spleen stays large. As far as lab tests go, with most of our diseases that we'll be talking about, in relation to the liver, we're going to see increased LFTs and increased bilirubin. As far as treatment and prognosis goes, once a patient gets to the level of cirrhosis, it can't be treated. It can't be reversed. All we can do is try to help the patient be comfortable. And so that might come through paracentesis or maybe a TIPS procedure. So paracentesis is a procedure that can be performed to help alleviate the pressure or the symptoms of having ascites in the abdomen. Now, ascites is fluid within the peritoneum. Remember that the liver is responsible for albumin, and albumin acts like a sponge, right? It helps bring the extracellular fluid into the bloodstream so it can be processed and we can pee out our extra fluid. What happens in the case of a liver that's not functioning correctly, that albumin level is going to be low. Therefore, we don't have those little sponges floating around. And so the fluid just kind of backs up and it likes to collect then in the peritoneum. So a paracentesis then is the process of getting a little small tube. We poke a hole into the abdomen, and this is usually done under ultrasound. And we watch the needle go into a nice little pocket of fluid. And then they leave a little plastic catheter in there, and we draw out that fluid. And so by drawing out that fluid, we're relieving a lot of the pressure that's within the abdomen, and we're helping the patient just feel a little bit more comfortable. Now, it depends on the patient's disease as to how many times they need a paracentesis. When I worked in the hospital, we had some patients come once a week. Some came once a month. It really just kind of depended on where their process was and how much extra fluid they produced. Once we take that fluid out, especially for the first time, we usually send it then to the lab and they can look for infection in the fluid, or they can tell if there's any kind of cancer cells floating around in it. So here we are with a picture of that flexible tube. So under ultrasound, we take a look. We're trying to find an area that doesn't have any large amounts of bowel in it. We don't want to hit the liver. We don't want to hit the kidney. So we're making sure that we find a nice open area for this needle to be inserted. Mark the spot. Doctor comes in, pokes the needle in, threads the catheter through, and now we have this flexible plastic tube that'll drain the fluid out. One of the other terms that I mentioned about the prognosis and treatment for cirrhosis is the TIPS procedure. So TIPS stands for transjugular intrahepatic portosystemic shunt. And this is a minor surgery that's done within the cath lab. And so what they do is insert a catheter into the jugular vein, and they thread that down into the IVC and through the portal system. So we go jugular, IVC, into typically the right hepatic vein. And what they're going to do is create a bridge or put a shunt in that connects the right hepatic vein to the right portal vein. And so now what's going to happen is blood is going to come into the liver through the portal system, and some of that blood is going to go to the liver to get processed, hopefully, but some of that blood is going to go through the shunt and directly back into the IVC, into the circulating system. So this gives the body or the liver a chance to process the blood that it can without getting overwhelmed with all the systemic blood that's coming back. It's a really good option. It really helps out a lot of people, kind of gives the liver a break. But the only downfall to this then is that not all the blood is being filtered by the liver as it should be. So eventually it will be, because it will make it back into that system eventually, but it's just not as efficient of a system as we are with a healthy liver. So here's kind of a drawing then of the TIPS. So again, we have a shunt or catheter up in the jugular vein. They thread that down through the IVC and take a turn into the right hepatic vein. They then create this connection from the right hepatic vein to the right portal vein. So as blood comes in, some will go to the left, some will travel through the liver, get processed, but some of it then will also travel straight through the shunt and back into the IVC. So we can see these TIPS shunts, we can see those by ultrasound, and it's quite often, if we know somebody has a TIPS, we want to make sure that it is patent, that it is completely open, not blocked off, not stenosed or anything. We want to make sure that the shunt is working appropriately. So let's take a look at what some of these look like by ultrasound. So in the early appearance of cirrhosis, typically what we're going to see is what we call a coarse echo texture. If you look at a normal healthy liver, it kind of looks, just kind of looks like soft. It should be very homogeneous, very smooth looking. With early cirrhosis, it's going to look kind of granular, almost like it's lots of little dots, lots of little sand pieces kind of put together. As we'd mentioned earlier too, in that early appearance, they're going to have hepatosplenomegaly, so a large liver and a large spleen. So here we are with our cirrhotic liver in the early stages. We can kind of see we're not even seeing the inferior tip here. We've got a very large liver going on here. So it's just kind of big. And we can kind of see then too that the echo texture of the liver is just kind of junky looking. It looks very granular. Now there's this other little box in here. This is a tool called elastography, which actually brings us to another key term for cirrhosis. So elastography is a test that can be performed with ultrasound. And as we saw with that little small box, that box is usually going to be placed somewhere in the 7th section or the 8th section of the liver. So up on that more anterior portion of the liver, we want to make sure that we are not in a vessel, in a vein, or in a portal vein. And what we want to do then is align this box over an area of liver tissue. And when we start the elastography process, the machine is going to send in a very strong burst of ultrasound energy. And we know that ultrasound is a mechanical wave, that it moves things, and so the machine then can tell how much did the liver tissue move. If it moved a lot, then we think it's probably pretty squishy, probably pretty normal then. If it doesn't move at all, then we know that that chunk of liver that was just sampled, that's going to be very stiff. And we find that stiffer livers are probably more fibrotic, more advanced levels of cirrhosis. So that's one way that elastography works. The other way that elastography works is that we look back at the stiffness and density and speed of sound. We know that the density and the stiffness changes how fast sound travels through the body. So another tool that elastography uses then is it calculates how fast do those echoes come back. Did they come back at the expected rate? Then it's probably normal liver tissue. Did it come back too fast? Did it come back too slow? That changes then what the liver is most likely made of. How stiff or dense is it? So we take multiple samples using elastography. Again, it uses a lot of ultrasound energy. So usually when you do an elastography study, you send the beam out. It gathers the information that it needs, and then you actually have to wait 2 or 3 seconds because you don't want to keep just blasting this one area with ultrasound energy. So you wait a couple seconds and then you can send another sample out. Not uncommon to get like 10 samples, and then you take the average of those samples, and that then is compared to a chart, which then tells us how stiff the liver is. And this is a really awesome tool that we have available to us now, because what used to have to happen is that these patients would have to go in and have to have biopsies, physical biopsies of their liver, so they could see how stiff the liver tissue has become. So with elastography, now we can do this in our ultrasound suites. We can do this every 6 months, not a big deal, and we can really track the progression of how stiff or how fibrotic the liver is becoming over time. Now, when we look at cirrhosis in the late stages, what we're going to see is that the liver has kind of shrunken down on itself. Remember, anything that does not work very well, anything that's kind of getting into that chronic stage, we start to see atrophy of it. If you think about, when you're using your muscles all the time and they're healthy, they're nice and plump, if you stopped walking, your muscles would kind of shrink down. So we start to see organs, or in this case the liver, not being used anymore. We start to see it shrink down on itself. It's also going to become relatively echogenic. We're going to see some nodular coarse echotexture, so we might be able to see the kind of the scalloped edges along the periphery of the liver. And what we commonly see in late stage cirrhosis is an enlarged caudate. So remember, the caudate lobe is supplied kind of with its own blood. It's also drained by the emissary veins that go directly in the IVC. So the caudate lobe is actually typically spared during cirrhosis. So it might be enlarged, it might be normal, or it might be even a little enlarged. But compared to the shrunken right lobe of the liver, it's going to look really pretty big, kind of juicy looking. The left lobe of the liver is also another area that is not as severely affected by cirrhosis. So you might see kind of a large left lobe, a large caudate lobe, and then this tiny little right lobe. In the late stage cirrhosis then too, we do see that splenomegaly. Remember that the blood is no longer going through the liver the right way, so that's going to back up into the spleen. And then lastly, we might see some portal hypertension. We'll cover portal hypertension a little bit more in depth in our vascular diseases of the liver. But in general, portal hypertension refers to the fact that blood can't go into the liver as it normally should be. So it creates more pressure, more resistance on the end side of the portal system. And because of that, then it backs up, causing that portal hypertension. So here we have a patient with advanced stage cirrhosis. We can see that the right lobe of the liver is very shrunken down, and we can see fluid around it. That's the ascites that we see quite commonly. And then you can kind of see along the edge here how kind of rough and bumpy it is. Very echogenic in appearance. So this is late stage cirrhosis. Again, late stage cirrhosis, we have kind of a smaller right lobe, but we have this gigantic caudate lobe here. So we can actually see the left lobe is kind of small right lobe, and then a very large caudate lobe. Here we have another example of a shrunken right lobe of the liver. We can see kind of those scalloped edges again. We can see that it's very echogenic. We have fluid surrounding, so that's the ascites. And as I had mentioned earlier, ascites is very irritating to the bowel and to the gallbladder. And so we'd start to see the gallbladder wall start to thicken up. Here we have the portal vein. If we look at our color map over here, blue is telling us that it's flowing away from the liver, out of the liver. And so that's not the right direction. We want our blood flowing into the liver through the portal system. It's coming from the spleen and from the gut. We want that to go get filtered by the liver. So in this case, we have blood flow leaving the liver, which is abnormal. That's that portal hypertension piece. Here's an example of a patient getting a paracentesis done. So this is the needle coming in through the skin line, being dropped into a large pocket of ascites. Again, the sonographer is going to help guide that needle in, finding an area that does not have excessive amounts of bowel. So this is bowel down here. We want to make sure that we're not hitting the liver. So we typically go either on the left side or the right side, but a little bit more towards the hips. Here's an example of the TIPS shunt within the liver. So we are up at the level of the hepatic vein. So this is the IVC here, and we can see the shunt traveling through the right hepatic vein. And then if we got a view of the right portal vein, we would see the other end of the shunt. Moving on, we have glycogen storage disease. Glycogen storage disease is seen in people who are unable to either break down glycogen into glucose or are unable to create glycogen. And so what ends up happening is, especially in the people who can't break down glycogen, these glycogen deposits are left all over the body, especially in the liver, but we also see them in the GI tract or even in the kidneys. So remember that when we eat, the glucose enters our bloodstream after carbohydrates are digested. Insulin is released. Insulin tells the cells to take in that glucose, kind of opens the door for that. And then anything that's left over is sent to the liver to be stored as glycogen. The liver then is supposed to store that glycogen until the body needs more energy, and it releases that glucose back into the body. Well, in the case of glycogen storage disease, the patient can't release that glycogen. They don't have the right enzyme to do that. So glycogen storage disease comes in multiple variations. The most common is glycogen storage disease number 1, which is also known as von Gurke disease. So remember that von Gurke disease is equated to glycogen storage disease. Those who are more likely to get glycogen storage disease are typically going to be of the inherited variant. You can spontaneously have it, but it is more likely going to be inherited. And it is an autosomal recessive disease. As a refresher, what autosomal recessive means, it means that when a child has a 1 in 4 chance of acquiring a disease, it is autosomal recessive. That means that both parents have to carry the defective gene to pass it on to at least 1 out of 4 of their children. If they don't have both genes from the parents, then the patient becomes a carrier of the disease and can pass it on, but they probably won't express the trait of the disease. So here we have a picture. We might have a carrier father and a carrier mother. They both have the genetic information for a disease. When their genes combine, then they can have a 1 in 4 chance of having a healthy child. They have a 50% chance of having carrier children, and then they have a 1 in 4 chance of having a child that will have the disease. So glycogen storage disease is autosomal recessive, results in this having to have 2 carrier parents, resulting in a 1 in 4 chance of having a patient with the disease. Clinically, these patients are going to be actually pretty young when they come in. We're talking like maybe 3 or 4 months because it happens pretty early. The patients are going to have hypoglycemia, so low blood sugar. They're going to have abdominal distension because the liver has become enlarged because it is storing that excessive glycogen. They might be sleepy all the time, and they might be kind of irritable, kind of colicky. And so we see with lab tests then that they are going to have that decreased blood sugar. And we might see as well, so for glycogen storage disease, the big one is to remember they're going to have decreased blood sugar. Just FYI, they might also have some increased lactic acid, lipids, or uric acid as well. Treatment and prognosis for glycogen storage disease then, the patients are going to be encouraged to have more carbohydrates. That way they do have the energy that their cells need circulating in the body more. The only kind of balance with that then is that we don't want so much that it has to be stored as glycogen later, but they do need to eat more carbohydrates and more often to make sure that their body has enough energy. On ultrasound then, we're going to see a very echogenic liver. It'll be enlarged, so we'll see hepatomegaly. And then glycogen storage disease is commonly associated with adenomas. And we'll talk about adenomas in another lecture series, in our benign series, but we'll get a brief look at them now. So here we have an example of glycogen storage disease. We have a very enlarged liver. It's echogenic, kind of dense. Remember, glycogen storage disease can lead to fatty infiltration of the liver. That's why it's big and echogenic. And what I want to point out here, this object that they're measuring is an adenoma. So an adenoma is just kind of a benign misconfiguration of liver cells. And so it's not a real big deal, but we do see them quite often with glycogen storage disease. Here's another example. We have enlarged liver, looks relatively echogenic, and then we have these darker adenomas within. So adenomas go along with glycogen storage disease. Glycogen storage disease is also known as von Gurke's. Probably the key things that you need to take away from this one. Our next disease then is hemochromatosis. Hemochromatosis then is the body absorbing way too much iron. And when we have too much iron, that can lead to serious diseases of the liver, heart, and pancreas. So remember, the liver is responsible for filtering and for storing iron and doing all of that. If there's too much iron in there, the liver is not going to function well. The iron deposits then can move into other areas such as the heart and the pancreas, which is also going to cause them not to function as well either. So So here we have a healthy liver on the left side, and what we find with iron, the iron deposits are going to kind of accumulate in islands within the liver. Hemochromatosis causes that iron overload. The excessive iron causes the hepatocytes to become inflamed or to cause hepatitis. The hepatitis then, the angry liver, can move into a chronic condition, which then can lead to cirrhosis. So hemochromatosis can end in a cirrhotic liver. It is most likely going to be inherited, but it can also be caused from other liver diseases or from blood transfusions. It's most likely going to be white people from Northern European descent, and men are more likely to have hemochromatosis than women. Clinically, these patients are going to have joint pain, they're going to have bronzing of the skin, fatigue, weight loss, and then we'll see those iron deposits are going to cause that liver, heart, or pancreas issues. So we're going to see liver disease, diabetes, or heart disease along with it. Here's an example of a patient who has hemochromatosis with that bronzing of the skin compared to the hands of a healthy patient. Lab tests are going to show an increase in iron as it has developed into hepatitis, and we'll also see an increase in LFTs and bilirubin as well. Treatment for hemochromatosis is typically to have excessive blood removed from the body. So you go to a phlebotomist, they're the ones that take your lab samples, your blood samples. You actually just go to the doctor, they take blood out, and that reduces the iron load within the body, and then the body will make more blood cells, and again, you'll just kind of go through the process. So by removing blood from the body, you're removing the amount of iron that is found within the blood. They can also, or should also, avoid iron-rich food and typically can manage disease fairly well. On ultrasound then, we're going to see a coarse echo texture to the liver, and we might even be able to see some of the iron deposits on ultrasound. So here we have the liver. It's kind of granular again, kind of that coarse echo texture, and then we can actually see one here. We can see the iron deposit here. Looks like there might be one here and one here as well, a little bit smaller. So this patient is most likely, again, going to have labs that are going to lead us to believing that they have hemochromatosis. They probably have a history of bronzing skin. They might have had a genetic test that tells them they have hemochromatosis. We just want to know what to expect on that liver ultrasound. And that brings us to the end of diffuse diseases. Hello and welcome back to another pathology lesson where we take a look at abdominal pathologies and what they appear like on ultrasound. Today's lesson is the second part in a 5-part series of liver pathology focusing on vascular pathology. We're going to begin this lesson then with portal hypertension. So portal hypertension is an increased blood pressure in the portal system, and this is typically going to be due to a high resistive bed caused by damage to the liver. Now, we talked about portal hypertension when we discussed cirrhosis. Remember, cirrhosis causes the liver to become damaged. The organ can't accept all the blood that's trying to come in from the gut, trying to come in from the spleen, and so it kind of puts up this wall to the blood. It becomes high resistive. When that occurs, the blood can't flow into the liver like it should, and so it starts to find other directions to flow. It starts to flow back to the spleen. The body starts to create new blood vessels for that blood to flow through. So portal hypertension typically occurs when the liver cannot accept all of the blood that needs to go to it. Those who develop portal hypertension are most likely already suffering from cirrhosis, but we can also see it occur in patients that have portal hypertension due to blood clots. So somewhere along the portal system there is a clot, possibly blocking it or almost occluding a vessel. We can see it due to infection of the liver. We might see it to extrinsic compression, so maybe a lymph node or a tumor in the pancreas might be squeezing the portal vein system, that main portal vein. or it might be idiopathic, occurs for no known reason. When a patient has portal hypertension, we commonly see that they also have ascites. They are very tired, some weight loss that goes along with it, and splenomegaly. Remember, all that blood is trying to go somewhere else, so it backs up into the spleen, causing the spleen to become enlarged. Some other things that we see with portal hypertension then are esophageal varices, encephalopathy, and a caput medusa. Esophageal varicosities occur when the body is trying to figure out what to do with all this blood. So remember, the esophagus is kind of a central tube that is connects our mouth to our stomach, and there's actually a lot of little tiny vessels that are feeding up and into the esophagus. And when a person has portal hypertension, these tiny little vessels start to expand, and so they become large, just like varicose veins in the leg. They become these tortuous vessels in the body that lead up to the esophagus. The problem with these esophageal varicosities is that they are very fragile. They are very prone to rupturing. And if a person has a ruptured esophageal varicose, what tends to happen is they will bleed into the esophagus, which then brings blood to the stomach. That blood in the stomach is no bueno, and they end up vomiting blood. And so if a patient is known to have portal hypertension, known to have cirrhosis, and now they're vomiting blood, this can be a very, very severe complication. It can lead to death very quickly. So if a patient is seen with varicoses, esophageal varicoses, we want to make sure that we're getting in there, and what they do is they cauterize them or clip them so they don't have the chance to rupture and bleed out into the stomach. So here's an example of an endoscope within the esophagus. We can see one of those esophageal varicoses is bleeding here, and so they're going to want to make sure that they block off the vessel so it stops bleeding, to have the patient keep the blood where it should be, not going into their stomach. This diagram down here, again, we have a cirrhotic liver, which is causing the portal hypertension most likely. The blood starts to back up through the portal system. As that backs up, there's going to be a backup of the blood vessels that go to the spleen, that go to the stomach. All of this is going to start to back up. As those back up, we start to see the tortuosity, increased girth and size of those esophageal vessels. They become large and tortuous, causing esophageal varices. So all of this pressure building up in the liver causes pressure to then build up back into the system as well. Hepatic encephalopathy is another thing that we see with patients with portal hypertension. Typically when the blood is going into the liver in the way that it's supposed to, it gets filtered of its toxins and the body's all hunky-dory. Well, what happens with portal hypertension is that those toxins aren't being filtered the way that they should be. The blood is backing up into places that it shouldn't really be going. So what happens then is those toxins build up within the blood. They affect the brain in a very particular way, and it makes them kind of confused and delirious, and can be kind of what seems unrelated but is very related to the liver not functioning. Caput medusa then is another thing that we can see clinically when a patient lifts up their shirt right around their belly button. What we will see with a caput medusa is kind of this pile of superficial umbilical veins. And it almost looks like there's little pile of worms right around their belly button. And again, that's because there's so much pressure in the liver that blood is just trying to get anywhere it can. It can't go to the liver, it's got to go somewhere else. And so it backs up into the system. We know that the ligamentum teres was originally the umbilical vein in the fetal circulation, and so that can actually open back up. When that opens back up, then the blood travels back towards the belly button and can cause those superficial veins to dilate as well. So this is actually something that you can visualize from the surface of the skin. And here we have an example of it. Again, so much pressure back in that liver, causing blood vessels behind it to dilate and become very obvious. So this is at caput medusae. Lab tests for portal hypertension, again, especially in the setting of any sort of liver disease, we're going to have an increase in LFTs and bilirubin. Treatment and prognosis for portal hypertension. The prognosis once you have portal hypertension is usually pretty poor. Your liver is probably already damaged to the point where it's clearly not functioning. There's not a whole lot they can do about that part of it. Their focus is going to turn then to helping the patient just be comfortable and to manage some of their symptoms due to the cirrhosis or due to the portal hypertension. So what we see with patients with portal hypertension, they can have that TIPS procedure done, which we talked about in the cirrhosis lecture. They can have a DSRS done. We can do those paracentesis for the ascites that's building up, and they're most likely going to be on some sort of blood pressure medication to help alleviate some of the symptoms. DSRS is another type of shunt that can be done similar to the TIPS, except for this time it connects the distal splenic vein to the left renal vein. So it's distal splenorenal shunt. So here we can see in our picture here we have the spleen. Remember, the splenic vein typically connects up with the superior mesenteric vein to go into the portal vein. Well, in the case of cirrhosis, all that's backing up and causing problems for everything downstream. And so what they do instead is detach the splenic vein and bring it into the left renal vein. So now the blood that's coming back from the spleen is just going to go straight to the left renal vein, into the IVC, and back through the heart. So it's really reducing the load of blood that is coming into the portal system. On ultrasound, then, we're typically going to see a patient exhibiting the signs of the cirrhotic liver. Looking directly at the portal system, we're going to see hepatofugal flow in the portal vein. The portal vein is most likely going to be enlarged, measuring from 13 to 15 millimeters as a minimum, and then we'll see some recanalization of veins in the area. So here again we have that cirrhotic liver. We have the scalloped edges, coarse echotexture, we have ascites around it, and we have the shrunken right lobe in this image. So cirrhotic liver is very common with portal hypertension. In this image, we are seeing the portal vein coursing into the liver. Typically, when we look at the portal vein and the hepatic artery, we expect them to be flowing in the same direction. So we expect them to both be red. That is normal, healthy, standard setup for ultrasound and looking at the portal vein. So we do expect the blood coming into the liver to be flowing into the liver. In this example, though, we can see that the hepatic artery is traveling into the liver, but the portal vein is heading the opposite direction. So when blood is flowing out of the liver, we call that hepatofugal flow. So a way to think of that, fugal, fugitive, so you can think of the blood running away from the liver, just like a fugitive would run away from police officers. The opposite of hepatofugal flow then is hepatopedal flow. So the hepatic artery is flowing hepatopedal, flowing into the liver. A lot of people think of pedal kind of as pedal. You pedal your bike towards something. Just remember that hepatopedal flow is spelled with a T, not pedal, like pedal on your bike. Here we have an image then of the hepatofugal flow in the splenic vein. So we can see the pancreas here, and remember the splenic vein runs right along the pancreatic tail. So typically we want the blood flowing coming from the spleen around the tail up towards the transducer at this point before it confluences into the portal vein. So this splenic vein is being shown as blue. We can see from our color map here that blue means away from the transducer. So this is indeed flowing away from the transducer in the wrong direction. We can then see by our Doppler waveform here that it is also below the baseline, again flowing away from the transducer, flowing away from the liver, causing that hepatofugal flow. So we've thrown out the terms again, hepatofugal and hepatopedal. Remember again that hepatofugal is flow away from the liver. In the portal vein, this is abnormal. Hepatopedal flow is what we expect both in the splenic vein, in the portal vein, in the hepatic artery. This is all blood flowing going to the liver, which is the normal direction for those vessels. I also mentioned that the portal vein itself typically becomes enlarged. So we like to take a measurement of the portal vein kind of at the main portal vein area, right at the porta hepatis. If the patient is just breathing normally, laying on their back, we expect this to be under 13 millimeters or 1.3 centimeters. So we can see in this picture here, it is measuring 1.9 centimeters or 19 millimeters, which would be considered enlarged. We also find that some of the vessels in the area become recanalized. I had mentioned with the caput medusa that the ligamentum teres will recanalize. It used to be the umbilical vein. Again, the body is awesome and tries to find ways to move this blood somewhere else. And so the ligamentum teres recanalizes or opens back up again and serves as a way for blood to head back out of the system. So we've got the portal vein here coming in. That's going to branch into the left portal vein, and what ends up happening then is that the ligamentum teres kind of connects up to that area, and some of that blood is going to get shunted out of there. So we see typically a vertical vessel that comes out of the left lobe and starts heading towards the umbilicus. Here's another example of it. So we've got, again, the ligamentum teres has recanalized. We have that vessel then that heads off and towards the umbilicus. That's typically how we can find it. I actually had a recent patient that had some portal hypertension, and I don't know, something just looked weird about their left lobe, and I threw color on, and it wasn't super obvious in the black and white pictures like this picture, but I put the color on, and this beautiful recanalized ligamentum teres popped up, and I was like, whoa, look at that. And then when I started to evaluate the portal system a little bit more, saw the hepatofugal flow, and we were able to get them that diagnosis. So kind of an interesting case. It's always interesting to see this. If a patient has this recanalized ligamentum teres, definitely take eyes down to the belly button, see if there is that caput medusa. Take some images of that area if you see it. In this picture, though, we can see that scalloped edge, very increased echogenicity of the liver, ascites surrounding as well. So all hallmark signs of cirrhosis, which leads to portal hypertension. The next vascular disease that we're going to talk about then is kind of a combo disease process. We have the portal vein compression, or we have portal vein thrombosis. So the compression piece of it is going to come from more extrinsic things like lymph nodes or masses, where the thrombus is going to be more of an internal blockage due to some sort of blood clot within the system. So again, extrinsic is pressure on the portal vein causing it to collapse, typically leading to obstruction. Portal vein thrombosis then is going to be an internal blood clot within the portal vein that causes obstruction. So we have extrinsic pushes the portal vein walls shut to obstruct it, where portal vein thrombosis is going to be a blood clot on the inside causing obstruction. The incidence then of portal vein compression is typically, again, going to be due to adjacent tumors. So maybe a tumor within the liver, a tumor of the biliary system, maybe a tumor of the pancreatic head. All of that kind of central blood area, it's a very congested area for things happening anyway. So any tumors in that area can cause compression on the portal vein. We might also see it then due to lymphadenopathy. Lymphadenopathy is large lymph nodes. There's a lot within the area of the porta hepatis, right where that portal vein is traveling. So again, we might see some compression due to large lymph nodes in the area as well. People who develop portal vein thrombosis are typically going to have some sort of underlying disease that goes along with it. Most commonly, we're going to see it with HCC, or hepatocellular carcinoma, which is a primary cancer of the liver. We might also see it in patients with portal hypertension. Remember that blood flow is flowing in the wrong direction in portal hypertension. It's not flowing at nearly the same rate, and so the blood can kind of start to get sticky on itself and start to kind of block things up. Same idea with pancreatitis. Pancreatitis is an inflammation of the pancreas, and that kind of infection can start to invade into the portal walls and cause blood clots in that sense. Same idea with cholecystitis. Infection can kind of drop into the portal vein system. But then we also see portal vein thrombosis occur with pregnancy, birth control pills, and surgery as well. So anything that can cause clots around the body can cause clot to form in the portal vein as well. We just most likely see it with portal hypertension and with carcinoma of the liver. Clinically, these patients are going to come in with abdominal pain. They're going to have hypovolemia, fever, and nausea and vomiting. Hypovolemia is the condition of having too little blood within the system. So if you think about it, the majority of the blood is going to head out through the portal system and into the liver to get circulated. Well, if the liver isn't really accepting blood because of an obstruction, then that might cause not enough blood to be out in the rest of the circulatory system. And so patients might become dizzy or weak due to the fact that there's not enough blood to support the rest of their body. Lab tests will see an increase in LFTs because the liver is most likely not functioning. That is what has been then the cause of compression in the area or thrombosis to develop. And we might also see an increase in white blood cells. What you'll see in patients with blood clots is that they tend to have an increase in white blood cells as well. It's very common that we see this in like ICU patients. Their white blood cell count increases. They might have a fever that goes along with it. Most likely the doctors up there are going to order some sort of blood clot, ultrasound usually of the legs, but knowing that blood clots can occur anywhere in the body, we might actually end up finding one in the portal vein as well. As far as treatment and prognosis, if there is thrombosis that we can see, it's usually just treated with blood thinners. They can go in and roto-rooter it out if they need to, but more often than not, it's just going to be treated with some sort of blood thinner. Compression causes of obstruction are going to require that cause to be removed. So removing the tumor, removing the lymph node, but that's not always a viable option. Not all cancers, not all tumors can just be removed. On ultrasound then, we're going to see echogenic material within the portal vein if there is thrombus in there. We might also see cavernous transformation, and we might be able to identify the extrinsic cause of compression, be it lymphadenopathy or a tumor. So here we have a picture of the portal vein. We can see color on everything else. There's flow in the hepatic, there's flow out in the parenchyma of the liver, but we are not seeing flow through the portal vein. So the portal vein has thrombus within it, causing it to be blocked. I bet if we went further down, looked at the splenic vein or looked at the splenic hilum, we would see blood flowing in the wrong direction. I mentioned cavernous transformation earlier. Cavernous transformation is kind of like varicosities that pop up around the porta hepatis. So here we have, actually this is probably a better picture. Well, okay, we'll start with this one. We can see all those kind of congested tortuous vessels at the porta hepatis. We put color on, they all start to light up. So again, it's just a way for the blood to figure out, how do I get blood out of here into a spot that maybe it can do something more than what the liver can accept. And so we see extra vessels to kind of hold on to that extra blood. So again, cavernous transformation refers to the portal vein becoming obstructed, either by thrombus or by compression, and then multiple tortuous veins develop at the porta hepatis. Here we have a tumor at the porta hepatis. So this is the tumor, and it is compressing then the main portal vein wall. So here we have a patent portal vein, and we can see right by that tumor, it's getting compressed in. So we can kind of see a little bit of it here. It's compressed right through here, and then it opens up again on the other side. So tumors at the porta hepatis can cause compression as well. Portal venous gas then is the next pathology that we will talk about. Portal venous gas refers to gas within the portal veins or in the mesenteric veins. This is typically going to occur due to ischemic bowel disease. So ischemic bowel disease is when the gut is not getting enough blood When that happens, it starts to die off, it starts to necrose. We know that necrotic structures give off gas. If you think about really anything that, like think about old food in Tupperware. If you let that just sit in there long enough, the breakdown of that food is going to release gas, and sometimes then you get kind of like this bulging gas Tupperware. Maybe none of you have ever done that before. I have done it more than I care to admit, but dying things give off gas. And so that's why we see in ischemic bowel disease, we see gas then enter into the bowel. And because the bowel is all connected to the portal venous system, then that gas can kind of back up into the portal venous system, and then we can see the gas on ultrasound up in the liver or along the portal veins. Some other reasons that portal venous gas can occur is in diverticulitis. So that's again another disease of the bowel in which the little outpouchings in the ileum start to get infected. Again, those can cause some gas issues. Appendicitis, again, another infection, bacterial infection, builds up of gas. IBD is irritable bowel disease. We can have bowel obstruction, cancer of the GI tract, are all bowel reasons why gas can get back into the portal venous system. And then some surgical reasons that gas can get in would be the placement of a TIPS or an endoscope of the bowel. That can just cause air to get into the system, and then we can see it in the portal veins again. So clinically, these patients are going to have abdomen pain and possibly some abdominal distension. They're most likely, again, going to have a history of IBD or IBS, diverticulitis, appendicitis, something like that. There aren't any lab tests that go along with this. Treatment and prognosis of portal venous gas used to be kind of a death sentence. The prognosis was poor, especially in the setting of ischemic bowel. Now that we know that it can occur with diverticulitis or some other not as emergent diseases, it actually can be managed fairly well in other ways, is what we're figuring out. A big place that we saw this portal venous gas in the setting of ischemic bowel was in the setting of newborns, or especially premature newborns. Their circulatory system was not prepared to bring enough blood into their gut, therefore their gut started to die off, and this portal venous gas then would occur along with what's called necrotizing enterocolitis, where again the bowel is dying, causing that gas to be released. So on ultrasound, what we will see are really bright reflectors that align with the portal system. So if you think about how the portal vein branches in the liver, and we know we can recognize those portal veins because they have a little bit thicker, brighter walls. What we'll see then within those walls are these bright reflectors, and we might see a little bit of dirty shadowing or ring down artifact behind them. And they actually kind of just look like little bubbles within the system. They might move around a little bit, especially as the patient is breathing, but the big sign here is that we have bright reflectors within the portal system with that ring down artifact. So I have a video here that I'm going to try to play for you. This is actually, I believe, of a dog, but same idea. You can kind of see on this first picture here, we've got these bright reflectors kind of traveling along with the portal system. And you'll kind of see when we go live here what it looks like. Oh no, this one wasn't a dog. This one is actually a newborn. So you actually can see the gas bubbles in the portal system here, but then we can see how they're getting caught out in the further, more tiny branches of the portal system. So this is that portal venous gas. And you can see how there's kind of just these little bright reflectors. If you were to pause this and look very closely, you'd see the kind of like these ring down artifacts coming off of them. All right, our next disease process is called Budd-Chiari syndrome. And Budd-Chiari syndrome occurs when there is an occlusion of hepatic veins, and that occlusion or that blood clot can start to extend into the IVC. So typically Budd-Chiari syndrome is going to be a result of a patient with coagulation abnormalities, so they're more likely to develop blood clots. Maybe they have a genetic predisposition to having blood clots, or they've had some sort of incident that is going to cause them to create blood clots. They might also have primary liver cancer, that HCC, and so that tumor can actually block off a hepatic vein and then travel into the IVC. So it's not always blood clots, it can be tumor or blood clot. Again, thrombosis, OCP is again birth control or pregnancy. So anything that can make a person more prone to developing blood clots can make them more susceptible to developing Budd-Chiari syndrome. I would say more often than not, though, it's going to be some sort of tumor invasion is where we typically see the Budd-Chiari syndrome coming from. Clinically, these patients are going to have ascites, hepatomegaly, splenomegaly, and probably some upper abdominal pain. So the hepatic veins are responsible for bringing blood out of the liver. If that out is blocked, that's going to cause everything to back up again. So we see hepatomegaly and splenomegaly because of it. The ascites again occurs because that blockage is going to make it so the liver can't get rid of all of its toxins, and then the hepatocytes are going to become affected, and then everything just kind of gets angry, so the albumin goes down. So it's all linked together. If you can't get blood in to the organ or blood out of the organ, it's going to shut down and start malfunctioning. On lab, then, we're going to see an increase of LFTs. Treatment and prognosis, blood thinners or some sort of clot buster is going to be used to treat if the cause is due to thrombosis within hepatic veins or into the IVC. But the prognosis really ends up depending on the underlying cause. If it's hepatocellular carcinoma that's extended into the blood vessels, that's going to carry a very grave disease or grave prognosis. They are most likely going to die from that very shortly. So blood thinners can be fixed. Other causes, most likely not. On ultrasound then, we might not see the hepatic veins. That might be because they have filled with clot or filled with tumor, so we no longer see them as their anechoic structures that we expect them to be. If we can kind of see them and make out where they are, we might be able to see thrombus then in the hepatic veins. If we put color on them, we might not see any color flow through the hepatic veins. We might see a narrowing of the IVC, especially as the tumor or the thrombosis extends into the IVC. And we might see an enlarged caudate lobe. Remember that the caudate lobe is drained by its own set of veins, so it's not connected to the hepatic system, but those emissary veins drain directly into the IVC. So if the IVC is blocked, then the caudate lobes can't drain through the emissary veins like it should, and so the blood will back up into that and cause it to enlarge. So here we have a transverse view of the liver at the level of the hepatic veins. The bold arrows are pointing to the hepatic veins. We can see that there is material within them, most likely thrombus. And then the small arrow here is pointing to the IVC. We can see that there's extension of the thrombus into the IVC, making that narrow. Here's another example of Budd-Chiari syndrome in which we have a blocked hepatic vein. We're seeing flow in the IVC, we're seeing flow out in the right hepatic vein, so there's clearly something blocking this middle hepatic vein. And that is the end of our vascular disease and liver pathology. Today is the third part in our 5-part series of liver pathology, focusing on focal benign disease. We're going to begin today then with hepatic cysts. So the hepatic cyst is a cyst anywhere else that we find in the body. It's just a fluid-filled sac in the liver. We have variants of the hepatic cyst. We can have simple, congenital, or peribiliary cysts. The rate of seeing hepatic cysts is actually pretty low, at less than 5% of the population, and those with hepatic cysts are more likely to be female. As far as clinical signs and symptoms go for hepatic cysts, it's actually most likely going to be asymptomatic. They can become symptomatic if they become very large and start to obstruct something within the liver, like the biliary tree, or if they start to bleed into themselves, that can be kind of painful as well. More often than not, though, hepatic cysts are going to be what we call an incidental finding, be it on a CT or on our ultrasound. Maybe they've come in for right upper quadrant pain. Doctor's probably thinking some sort of gallstone. We do our scan, we see this liver cyst, probably has nothing to do with what they're feeling. It's just a finding that we had. We know that cysts can be found really in any organ within the body. And when they are in the liver, we call them hepatic cysts. And cysts in general, again, anywhere in the body, can turn into hemorrhagic cysts. Hemorrhagic cysts are when those cysts start to bleed into themselves. Cysts kind of have this epithelial lining on them. For whatever reason, that epithelial lining can kind of break away, and when it does, it breaks tiny little blood vessels that are on the outside, and then we start to have some blood coming into the cyst on itself. When that happens, then the blood is irritating to the area, and then that can cause some pain. So not super common in the liver. We see quite often hemorrhagic cysts on ovaries. It's probably the more common spot that we're going to see them, but we can see them in the liver. Anywhere that cysts do populate, we can see hemorrhagic cysts. There aren't any lab tests that go along with hepatic cysts. As far as treatment and prognosis goes for hepatic cysts, they are such a non-big deal. Like, nobody cares that you have hepatic cysts unless they become hemorrhagic, unless they become really large. So for the most part, there's no treatment. The prognosis is just fine. Most people don't even know they have them. If you're in that small population that ends up with a large cyst, then surgery can be helpful, but it's not always successful. On ultrasound, then, we are going to see classic cyst signs, which include a smooth, thin wall. The contents should be anechoic, and they should exhibit through transmission. If we see peribiliary cysts, those are going to appear as small cysts that are near the porta hepatis. Or if we see hemorrhagic cysts, then we're going to see cysts with internal contents. So here we have an example of liver cysts. Again, they have small, thin walls, anechoic insides, and we're seeing that through transmission or posterior enhancement. Now, at the beginning of this, we talked about acquired versus congenital cysts. As women age, they're more likely to develop cysts, so those would be considered the acquired version. If you are born with a hepatic cyst, then that is a congenital cyst. Unless we look at the infant immediately after birth, or maybe even see it in utero, we are not going to be able to determine at a later point in life if it's congenital versus acquired. Here's an example of a hemorrhagic cyst. We can see, again, thin walls, but now we have internal contents to our cyst. If we were to put color on this, we would most likely not see any color within these echogenic pieces, so that's reassuring that it's hemorrhagic, but we might see some peripheral vascularity. Here's an example of peribiliary cysts. Again, peribiliary cysts are tiny, itty little cysts that show up near the porta hepatis, and they look just kind of like little tubule cystic-y structures. Our next disease process is the polycystic liver disease. Now, polycystic liver disease, you can probably kind of already figure out what it is. Poly meaning many, cystic, cysts, so many cysts of the liver. To officially be diagnosed with polycystic liver disease, an individual must have at least 10 cysts that are separated from one another. Here's an example of a gross specimen of a polycystic liver disease patient. So they're actually doing a liver transplant on this patient. And so this is the polycystic liver disease in the background here. All these little bubbles here are cysts, so they clearly have more than 10. This part that they're holding onto here was one giant cyst that they actually needed to bust open so they could get the liver out. Compare this then to this normal liver in the forefront. This is what they're going to put into the patient. This is what the patient got rid of during the liver transplant. So kind of insane how the body can change, how the liver can progress with this polycystic liver disease. It'll make sense then why the patients have symptoms that they have when we take a look at those. for how big this liver is. You would think that's going to cause some issues on the inside, right? So as far as incidence goes with polycystic liver disease, it is typically inherited. It can be spontaneous, but it is typically inherited. And what we see is that it's an autosomal dominant disease, and that 1 in 100,000 people have this disease. So it's actually pretty common, and it's pretty common because it's inherited and because it's autosomal dominant. There's a higher chance of passing that disease along. Females tend to have the disease more severely. Cysts respond to estrogen in a different way. And so with that extra estrogen in the body, it makes sense then that females are going to have an increase or more severity of these cystic properties. The other thing that we see with polycystic liver disease is that patients commonly have concurrently polycystic kidney disease along with it. So I mentioned autosomal dominant, just like we reviewed autosomal recessive. Autosomal dominant causes a patient to have a 50-50 chance of inheriting the disease. So we can have one parent that's affected that mates with another parent that is unaffected, and because of the way the genes work, they have a 50% chance of having affected children and a 50% chance of having an unaffected children. So autosomal dominant gives a 50-50 chance of having the disease, where autosomal recessive is a 25% chance of having the disease. Clinically, these patients typically are going to be asymptomatic up until about the age of 50. As you saw in that liver transplant picture, you saw how big those cysts were, how big the liver had gotten. It's kind of a progressive disease. The cysts are going to start out smaller, fewer, and then they're going to progress to more, and they're going to get bigger and bigger and more. And eventually, the patient is going to start to have symptoms. And so that's why it's typically not until after the age of 50. Once they do start having symptoms, what typically happens is that their liver is going to feel very large. It's going to be enlarged. You saw the picture of it. It was huge. So the cysts and just the liver itself becomes very big. As the liver increases in size, it makes sense then that it's going to put pressure and move things around that can cause some abdomen pain. So that's another common thing that occurs. Dyspnea and reflux are another thing that occurs. That makes sense too. As that liver increases in size, think about taking a really big breath in and think about how nothing's moving with that giant liver in there. So it's actually going to be hard and painful to take really big breaths in. And then reflux, that liver is probably encroaching on the stomach. And so it makes sense that it might squeeze some of the hydrochloric acid back up into the esophagus, so they might have that acid reflux that goes along with it. There aren't really any lab tests that go along with polycystic liver disease. And as far as treatment and prognosis goes, there isn't a treatment. There's no way to stop these cysts from occurring, but they can help to manage some of the symptoms. And one of the ways that they can do that is through cyst fenestration. Basically what that is opening up the cyst so all the fluid out of it leaks out and back into the system, which will get absorbed. And then they kind of cauterize off that cyst so it doesn't reform again. And they're not going to do that for every single cyst, because that would be a possible cause for where an infection could come in or something like that. They're just going to do that for the really big symptomatic cysts. As far as ultrasound goes, we say that polycystic liver disease makes the liver look like it has a cluster of grapes to it. So there's going to be lots of multiple simple cysts, that cluster of grape appearance, and what we might see is that some of them may look complex or might look hemorrhagic. When you are scanning a patient with polycystic liver disease, if it's the first time they're being scanned, take lots and lots of pictures. You want to kind of give a good baseline, kind of mentally count as you're sweeping through how many cysts there are. Take cine loops so the radiologist can count how many cysts are there, because if there's more than 10, then they're going to get this polycystic liver disease diagnosis. And then you also want to make sure that you're looking through for anything that looks not like a simple cyst. Are there any hemorrhagic cysts? Measure those. Are there any complex cysts? Measure those. And then after that, if it's really just kind of all simple cysts, typically what's done is maybe the biggest 3 are measured. Maybe you'll do the top 2 in each lobe. Kind of depends on what your radiologist wants. By no means do you need to measure every single cyst within the body. So here is an example of the polycystic liver disease. Again, we can see just tons of simple cysts throughout the body. There's going to be islands of normal hepatocytes kind of shoved in between all of these, so the liver still is able to function, surprisingly. It's just got a lot of extra little fluid pockets within it. Here's another example of polycystic liver disease. Again, we're not going to measure all of these. If this was the picture, I'd probably measure just this one and talk about the largest in the right lobe. Our next disease then is the hepatic hematoma. So in general, hematoma is really just a collection of blood outside of a vessel. We expect blood to be in the blood vessels. We can see it by ultrasound. Once the blood leaves the blood vessel, we have now created a hematoma. A hepatic hematoma then is a collection of blood involving the liver. People get hepatic hematomas most commonly from some sort of blunt trauma. So we're talking like an MVC, a motor vehicle crash, maybe from being in a fight, from a big fall, some sort of blunt trauma, getting kicked by a horse. I don't know. You probably get the idea. Some other ways that we can have hepatic hematomas are through surgery, biopsy, or bleeding disorders. So patient has surgery on their liver that can cause the liver to bleed and cause a hematoma. It's not uncommon for biopsies of the liver to result in a hematoma. Or if a patient has a propensity to have thinner blood, they might have a bleeding disorder which causes them to bleed more easily, might develop in a hematoma as well. Clinical symptoms and signs of a hematoma are typically going to be abdomen pain. We're going to be much more concerned about it if it's abdomen pain following surgery, abdomen pain following blunt trauma. Lab tests, then, we're going to see a decrease in hematocrit. Remember, hematocrit tells us how many red blood cells are within the blood. Anytime there is a decrease in hematocrit, that means that there is an active bleed somewhere in the body. So decreased hematocrit can be a result of a hepatic hematoma, a recent bruise somewhere, recent surgery, menstruation, but there's active bleeding somewhere in the body. So if we have a patient just in a motor vehicle accident, having abdomen pain, decreased hematocrit, you betcha we're going to be looking for a blood source somewhere within the body. Treatment and prognosis then is really going to depend on the severity of the hematoma. Is it just a tiny little thing around the liver? Probably just going to be reabsorbed, like the body reabsorbs bruises just fine. No big deal. If we get into a very large hematoma or multiple lacerations on the liver, then that patient might need to go to surgery to fix those. On ultrasound then, the appearance of the hematoma is mostly going to depend on the stage of the blood. So when blood is actively bleeding, it is anechoic. Think about it being in your blood vessels. It's anechoic, right? It's doing its thing where it's supposed to be anechoic. So brand new blood is anechoic as well. Once the body realizes that that blood is going somewhere it shouldn't be, as in a hematoma, it's going to start sending out clotting factors to that area. And so what happens then is that as blood starts to age just ever so slightly, we're going to see those clotting factors come in, and the blood is going to start to look hyperechoic. And the more clotting factors and the more clotting that happens, that blood is going to become more and more and more hyperechoic. And then what happens after all that blood is clotted off, when the body starts to reabsorb it, it actually starts to become more complex because it's starting to liquefy again. And we know that liquids tend to be a little bit more anechoic on ultrasound. So new blood is anechoic, clotted blood is typically hyperechoic, and then super old blood that's in the process of being reabsorbed and breaking down turns complex with fluid and solid pieces within. When we are evaluating the liver for hematoma, it's important that we decipher, is this a subcapsular hematoma versus a parenchymal hematoma? So this first picture here shows us a subcapsular hematoma. And we know it's subcapsular because of a couple things. First off, we can see the liver tissue here. And we can also see the diaphragm underneath it here. All right. And the other thing that we know that this is going to be a subcapsular hematoma is because of the way the liver tissue bends around the hematoma. So This hematoma is found in between Glissen's capsule and the liver parenchyma. And the hematoma is pushing the liver parenchyma away from the capsule. So that makes this a subcapsular hematoma. Here's another example of a subcapsular hematoma. Again, we can see the diaphragm along the edge here, and then we can see the blood pushing the liver away from the capsule. Another way to kind of think about subcapsular hematomas is the blood kind of following the shape of the liver that we expect it to be in? Because then it's most likely subcapsular. It's staying within the capsule, the shape of the liver. So subcapsular, again, is defined as a bleed between the liver parenchyma and Glissen's capsule. The liver parenchyma is usually concave to the bleed. Here's another example of it. We've got that concave kind of pushing away of the liver parenchyma, subcapsular. We can compare that then to an intraparenchymal hematoma. Intraparenchymal hematomas are going to be found within the liver tissue, typically then surrounded by liver tissue. So here we can see a rather large intraparenchymal hematoma. It's very complex looking, so this is most likely an older bleed, but we can see the liver tissue around it. So intraparenchymal hematomas are completely surrounded by liver tissue, and we tend to see them be kind of like round, spherical in shape. So this picture again shows us an example of a subcapsular, a larger subcapsular hematoma, but then it also shows us a intraparenchymal hematoma. The other thing that we need to be concerned about when a patient has hematomas or has recent blood trauma and we see blood within the abdomen, then we call that a hemorrhage. And so if there is free blood within the abdomen that is progressively getting larger, getting more severe, they might actually be actively hemorrhaging or losing blood into the peritoneum. So, if this was on a patient that just got in an accident and we're seeing all this kind of complex fluid out in the bowel, we might be more concerned that this is actually hemorrhaging from somewhere. Compare that then to the patient who maybe just has a history of cancer, then we're less likely going to be concerned about this being blood. So again, history is so important for which direction our differential diagnoses will go. This slide shows us a really nice progression of how blood ages. So again, we kind of have this more anechoic appearance to new blood. As it clots off, we start to see that the blood becomes more hyperechoic or even isoechoic to surrounding tissue. And then as that blood starts to break down, we'll start to see parts of it become liquefied and the body will reabsorb it. Our next pathology then is hepatic hemangiomas. And a hepatic hemangioma, basically defined, is a mass of tangled blood vessels. And hepatic hemangiomas can also be known as cavernous hemangiomas. You can have hemangiomas anywhere in the body. Again, if they're found in the liver, that's what makes them the hepatic hemangioma. The hepatic hemangioma is the most common benign liver mass. Highlight star, underline that. Most common benign liver mass is the hepatic hemangioma. And these are found in about 5% of the population. My personal feeling is that it's probably more than that because I've seen tons of these over my years of scanning. But they are most likely going to be found in female patients in between the ages of 30 and 50 years old. Hemangiomas are typically asymptomatic, and there aren't any lab tests that go along with them either. Treatment and prognosis is very good. There's no treatment for them. Usually, again, an incidental finding, so there's really no cause for concern when they are found. On ultrasound, then, it's very important to understand what the hepatic hemangioma appears like on ultrasound. It's a great board question. So they are hyperechoic, they can be solitary or multiple, and they're usually found in the right lobe of the liver. And here is an example of a hepatic hemangioma. They really stick out. And so it's kind of fun when you see them. You're like, oh, I know exactly what that is. Take your measurements of it, put color on it, good to go. What's interesting about hepatic hemangiomas, we talked about these being a tangled ball of blood vessels, but the blood vessels are so itty bitty that if you put color on these, you're actually not going to see any color flow in them. Here's another example of some hepatic hemangiomas. Again, really bright, clear borders on all of these, most likely within the right lobe of the liver. Now, something with hepatic hemangiomas, again, just my personal feeling about them, whenever I find them, I usually find them way out on the edge. So that's why it's so important that you are really sweeping all the way up through the dome, all the way back down through the inferior portion, really looking at that periphery, looking at all the parenchyma, because I feel like I find these hemangiomas way out on the edges. Again, another example of a hemangioma with a color box on it. They do not show color typically within. This is an atypical presentation of a hemangioma. We've been showing pictures of very bright hyperechoic hemangiomas, but in this case, this patient actually has fatty liver. So the liver itself is already very echogenic, and so the way that the adenoma appears in the fatty liver is actually hypoechoic. And so that's kind of an abnormal presentation. This might be more concerning for some sort of tumor or possibly some other sort of mass. Most likely it was biopsied and determined to be a hemangioma, or possibly even had an MRI to determine it being a hemangioma. All right, our next pathology then is focal nodular hyperplasia, often abbreviated down to FNH. So FNH is a benign tumor, and this is where it's important. It's made up of hepatocytes, Kupffer cells, bile ducts, and connective tissue. So it's made up of everything that you can find in the liver. It's all going to be kind of blobbed into this weird ball of tissue, and that's going to make up our focal nodular hyperplasia. Focal nodular hyperplasias are also known as hamartomas. Hamartomas, again, can be anywhere within the body. They occur when you get this unorganized collection of all the cells that make up that organ. So focal nodular hyperplasia, hamartomas in the liver are made up of all the pieces: hepatocytes, Kupffer cells, bile ducts, all of it. This ends up being the second most common benign liver of the lesion, and we see them more likely in younger women. Clinically, again, these patients aren't going to have any symptoms unless they become very large, in which they can then become painful, especially if they become large enough to obstruct the biliary system. There aren't any lab tests involved with this. And again, because it is typically an incidental finding, they are going to not have any treatments for them and carry a good prognosis. On ultrasound, though, these can be kind of tricky to see. They are isoechoic, because remember, they're made up of all of the liver tissue, right? They're made up of everything a liver is made up of, but it's in a weird ball, so it ends up being like the same echogenicity as liver. It's isoechoic to it. And so because of this, it's also known as a stealth lesion. They're really hard to see. Every once in a while, though, they will come along with a central scar, which actually might kind of draw your eye to the lesion itself. The central scar typically is a central blood flow area. So here it is. Here's your focal nodular hyperplasia. You can actually kind of see the border coming along this upper edge here and coming along down here. This is the IVC below it. So this is the focal nodular hyperplasia. You can see it's very isoechoic to the surrounding liver tissue. Here again is another focal nodular hyperplasia. We have a little bit more of a border down here. It actually might be pushing a portal vein in a different direction, which might be why that sticks out there. Remember benign structures typically push healthy tissue out of the way, where cancerous tumors are going to invade. So I think when this focal nodular hyperplasia pushes normal blood vessels out of the way, that becomes a little bit more obvious on that border. Here's an example then of FNH with that central scar. So the FNH is this area here, again, very isoechoic to the surrounding liver, but the sonographer put color on, and what we can see is that vessel that got pushed out of the way, but then we can also see kind of a central blood flow area. Without color, this area typically looks kind of a little bit darker, so it looks like a little donut there. All right, next on our list is hepatic adenomas. So we've already heard about hepatic adenomas when we talked about von Gerke's disease. So let's take a closer look as to what they are. So with the hepatic adenoma, these are going to be benign tumors made up of normal to slightly atypical hepatocytes. So let's compare that to an FNH. Remember, focal nodular hyperplasia was the hepatocytes, Kupffer cells, bile ducts, all of it. Adenomas are just the hepatocytes. And these hepatocytes are actually pretty normal, maybe a little off, but for the most part normal. Hepatic adenomas that are more commonly seen in females, and they have been linked to oral birth control. We also know that it is commonly seen in von Gerke disease. It can be up into, I believe it was like 40% of patients with von Gerke disease. 40% of them will also have adenomas. Clinically, again, these are asymptomatic, so you might see them as an incidental finding. They, of course, can become painful if they become rather large. There are not any lab tests that go along with it, and because of its benign nature, there's typically no treatment, and it carries a good prognosis. On ultrasound, then, we are going to see a hypoechoic structure with a ring around it. And so here is a picture of our hepatic adenoma. Again, adenomas can be anywhere within the body. This is a hepatic adenoma because it's made up of hepatocytes and found in the liver. So here we have that dark ring around the periphery, and then the nodule itself typically is going to be a little bit more on the hyperechoic side. Here are some more examples of the hepatic adenoma. Again, we can see the liver or the ring around it with the central area. Another one up here with the ring around it. And that brings us to the end of focal benign liver diseases. Hello and welcome to another pathology lesson where we've been studying abdominal pathology and its appearance on ultrasound. This is the fourth part in a 5-part series of liver pathology where we will be focusing on infectious disease. Now, infectious disease is probably one of my more favorite ones to lecture on just because there's a lot of going on with this one. So let's go ahead and get started. We're going to start with pyogenic abscess. So the definition of a pyogenic abscess is a pocket of pus within the liver due to a bacterial infection. So anything pyogenic is considered pus creating, pus, genic, creation of. So we have pus creating infections, and because we're looking at liver stuff, we're talking about liver abscess. People who are more likely to develop pyogenic abscess are going to have some sort of infection of the biliary tree. So cholecystitis is an inflammation of the gallbladder. Cholangitis is inflammation of the biliary ducts. They might also have some other GI tract infections, so like something like diverticulitis or appendicitis. Remember, it's all kind of connected through blood vessels that come up through the gut, through the portal vein system. It can get lodged into the liver then. So anything that happens in the gut can travel up to the liver. And that's going to be an important concept as we talk about a lot of these infectious diseases. They can also have osteomyelitis, infection of the bones, and then bacterial endocarditis, an infection of the lining of the heart, which can, again, anything in the bloodstream goes through the liver, can affect the liver. Clinically, these patients are going to have classic infection signs. So pretty much any of our patients that we're talking about in our infectious disease chapter here, they're going to have those classic infection signs, which include a fever, increased white blood cell count, possibly nausea and vomiting, anything that goes along with having an infection, being sick, like we traditionally think about it. So to go along more with the pyogenic abscess, then we have patients that have abdomen pain, nausea and vomiting, and pleuritis. Pleuritis is pain with breathing. Lab tests are going to show an increase in LFTs because this pyogenic abscess is affecting how the hepatocytes are able to function. And then we're also going to see an increase in white blood cell count. We consider that a classic sign of infections. The body doesn't want this pus there. It's sending out the troops to try to get rid of it. As far as treatment and prognosis goes, it really depends on the severity of the infection. If a patient has a pyogenic abscess within the liver, it has a real chance to get into the bloodstream where it can travel around to multiple locations, or it can just cause the blood itself to become so overridden with bacteria that leads to sepsis. So with that in mind, really strong antibiotics are needed for patients with pyogenic abscess, and those are most likely going to be administered via IV within the hospital. They might also decide to do surgery for these patients, in which they place a drain directly into the abscess. So they try to get all that gunk out of it. And so it doesn't sit in the body, it actually leaves the body through a drain. As I had mentioned before, if it gets into the bloodstream, it can be poor outcome due to sepsis. So a few of the things that we talked about in that, pigtail drains are something that can be done within the radiology department and are often guided by ultrasound. In the placement of a pigtail drain, ultrasound will find the abscess or the area that they're placing the drain into. A needle with a guide wire is inserted into the abscess. Following that, then a plastic tube or the drain is then inserted into the abscess. At the end of this plastic tube is this like little pull tab, and when they pull it, it causes the end of the tubing to curl up like a pigtail, kind of like a corkscrew. And so that kind of locks this tube into the abscess, and then it's connected to like this bulb outside of the body that'll collect all the drainings from this area. So ultrasound is quite often used to guide all that drain material, plastic drain material, into the abscess itself. So here's a picture of the drain. Again, this is the part that goes into the abscess itself. Once they pull this little tab here, it makes it curl up on itself, and therefore it actually lets the patient be very mobile with it. It's going to be very hard for this curlicue to make it out of the body so the drain doesn't fall out. Another term we talked about was sepsis. Sepsis is when an infection enters the blood, and when that happens, it's actually very, very hard to treat. And it's one of the top reasons for death in the hospital. The infections overload the body, gets into the blood, can no longer treat it effectively. There are lots of symptoms that go along with sepsis. Again, most of them being extreme infection symptoms. On ultrasound then, pyogenic abscesses are going to appear very heterogeneous. They're going to have irregular walls. Because these are bacterial in nature, there's going to be air and dirty shadowing within it. Remember that bacteria is producing different compounds such as air, producing that pus, all of that. And then what we might also see are fluid levels. So here's an example of our pyogenic abscess. Again, very heterogeneous, kind of these irregular borders around the outside of it, just kind of a junky looking area in this area. So if we had a patient that had this picture, fever, abdomen pain, we might start to think pyogenic abscess. Here is another example of a pyogenic abscess. These really bright lines are air within the abscess, and then we're getting that dirty shadowing behind it. So again, just a bunch of kind of gross yuck in the liver tissue. Here's an example of the fluid levels. So we call fluid levels, we consider it when there's kind of two different subsets of fluid within a structure. So within this pyogenic abscess, we kind of have more of a fluidy, probably cystic-y substance, and then we have a pus substance in it as well. And so when that patient moves, the thicker or heavier stuff usually kind of separates out to the dependent side of the body. And so we see these fluid levels. If we were to roll this patient over, then we would see that pus kind of settle out in a different direction. So that's the fluid level. Our next type of infectious disease is an amoebic abscess. And remember, pyogenic was bacterial based. Amoebic abscess is going to be due to amoebas. And specifically, they're typically caused by protozoa Entamoeba histolytica. And so what happens is that a person will typically ingest the Entamoeba histolytica, so it gets into the intestinal system. And remember, all that blood and all of that is coming back up from the gut, going in through our portal system up to the liver. So it stands to reason then that this amoeba can travel to the liver via the portal system. Amoebic abscess are commonly seen in patients who have recently traveled to endemic areas. These endemic areas are going to be places in which the food or water is contaminated. It can also have some incident rate connected to having anal sex. We know that the entamoeba is found within the intestines, within the colon, which can then get transferred to a patient via the anus. Clinically, again, these patients are going to have classic infection signs, including abdominal pain, diarrhea, since this is starting out kind of as an intestinal issue. And again, they might have pleuritis with pain with breathing. Lab tests then are going to show increased LFTs and increased white blood cell count if the amoebic abscess has moved its way to the liver. Treatment for the amoebic abscess then is going to be typically medications or aspiration, which means to kind of suck all of that out. On ultrasound, we're going to see another heterogeneous structure within the liver. This time it's going to have smooth walls and typically runs a little bit more hypoechoic. So pyogenic abscess was irregular walls, heterogeneous bright spots within it. Amoebic abscess is going to be heterogeneous, but now has more smooth walls. So here's an example of an amoebic abscess. Again, we have a little bit more smoother walls. The pyogenic abscess walls I felt were very hard to even really delineate where the walls were. They were very irregular, where we can actually pretty clearly see where the wall is of this amoebic abscess. We can see too that it's more on the hypoechoic side. Another example, heterogeneous, a little bit more hypoechoic, but again, we can see the wall fairly clearly all the way around. A couple more examples of an amoebic abscess. This one is a little bit more fluid filled, but smooth walls all the way through on both of these. Most likely, most of these will need to be biopsied to determine the exact cause of the lesion. Our next infectious disease then is the echinococcal cyst. Echinococcal cysts are going to be due to a tapeworm infection. This tapeworm infection then is going to cause cysts to form within organs. So if you think about tapeworms, we typically think about them being, again, in the intestines. They are going to eat all of our nutrients and grow within the intestines. We have feet and feet and feet of intestines that they can grow and grow and grow in. And then they have like these little spore egg things that come off. And they're tiny enough that they can make it through the blood vessels and into the portal system again. So again, via the blood system, via the gut blood going into the portal vein, weird gut things can make it up into the liver. Echinococcal cysts then are also known as hydatid cysts. Now, one of the hallmark things to know about echinococcal cysts is to know that these are more likely to be found in people who are in sheep herding communities. So we're talking about Africa, Middle East, or the Mediterranean. These are very rare in the US. And the sheep herding and echinococcal cysts just have to go together in your mind. It's going to be probably on your boards. I don't know why. They love this question. Echinococcal cysts, sheep herding communities. And the reason for that is the way that the tapeworm eggs actually get ingested by humans in the end. And I have a little diagram of it here. So it happens, we have an animal that's infected with a parasite, we'll say a dog in this picture. And so they have the parasite. The parasite creates eggs, and then the dog goes and poops out those eggs in the field. Well, then the sheep comes on by and eats the grass and the poop and all of that. And so now the sheep has ingested the eggs. And they go through the same process of developing adults in their intestines and shedding the eggs. But then they also have issues with these hydatid cysts or the echinococcal cysts going off to the liver and to the lungs and other places. Well, then these sheep are used for meat to eat, and that's how humans end up getting them usually, how they end up getting the tapeworm. And so the process just kind of keeps getting, or the cycle just keeps going over and over again, which is why we see them most likely in sheep herding communities. Clinical symptoms, the hydatid cyst itself is most likely going to be asymptomatic until it grows large enough or ruptures. Once it's large enough, it's going to start to cause abdomen pain and nausea and vomiting. If it ruptures, it can cause anaphylactic shock in people. So as far as lab tests go, there really aren't any that go along with it. Treatments are going to need an anthelmintic drug that can stop the growth of the cysts within the liver, kind of kills everything. Or what might happen is if they do have that anaphylactic shock, they can die from that. So kind of an all or nothing type thing with this a little bit. You find out you have the cyst, you take the drugs, you're probably okay. If you're unlucky and are one of those that are going to have the anaphylactic shock, then you're more likely going to die from it. On ultrasound, echinococcal cysts take on a lot of different appearances. So the number one thing we need to know was sheep herding communities. We're also going to talk about daughter cysts. Those are going to be the two things you really need to know about echinococcal cysts. So the first appearance that we can have of echinococcal cysts is what we call the water lily sign. Now this is not the tapeworm that we're seeing in this cyst. What this is a lining of the cyst that has broken off and is just kind of floating in there now. So this is the water lily sign, when that lining separates from the rest of the cyst. Daughter cysts then are exclusively related to echinococcal or hydatid cysts. So daughter cysts is the second key thing that you need to know. And what we typically see then are tiny, small cysts within a bigger cyst. Now, you may have heard of daughter cysts in relation to ovaries. That's actually the wrong term for it. Sometimes you'll see a similar appearance in an ovary. Those are called oophrous. Those are going to be called cumulus oophrous cysts, where you have these tiny little clusters of cysts that look like they're in one another on the ovaries. So true daughter cysts are related only to echinococcal cysts, which are typically found within the liver. Lastly, then we can also have the honeycomb sign. And the honeycomb sign then is going to be the whole cystic area with tiny little cysts within. Our next infectious disease is schistosomiasis. Schistosomiasis is due to a parasitic infection, again, that usually occurs along the GI tract, and it can also occur in the urinary tract. The urinary tract is pretty isolated to the bladder, where the GI tract version of it is the one that can travel to the liver. Schistosomiasis is also known as bilharzia or snail fever, again, because of the way that it's transmitted. The incidence of schistosomiasis is, again, typically in endemic areas that are going to have poor water sanitation, so not commonly seen in the U.S., more common probably in Southeast Asia or in some Latin America, South American cities. So what happens with schistosomiasis is that a person has the infection or the parasite within them, and this can be either in their bladder or within their intestines. And so then this person uses a water source to go to the bathroom. So fecal or urination, and that expels the parasite out into the water. So now the parasite is floating around, might be some eggs in there as well, also floating around, and these eggs find their way to a snail, and then they hang out with the snail and use the snail as a host to develop into more of a spore, I guess, for making this easy. That spore then busts out of the snail and now has a tail on it, and it can swim through water. And so what it does then, it finds a human that's hanging out in the water, and it will either go through the urethra back into the bladder, or it can be ingested into the mouth, or it can actually go through the skin as well. And so schistosomiasis is typically seen in areas where people use the water systems not only for bathing and swimming, but then also for unsanitary, but urination and pooping. So clinically, early stages going to result in a rash. If the little swimmy guy's spore got in through the skin, we might see a rash on the arm. It's going to be itchy there. It's an infection, so they're going to have fever, chills, cough, headache, all of that. Abdomen pain has been associated with it, joint pain, muscle aches, all these kind of things that you think about when somebody just doesn't feel very good. Late stage signs, though, with schistosomiasis is as that parasite hangs out in the intestines and drops off eggs, some of those eggs are going to travel through the blood system again, and they're going to get caught in the portal system, and they're going to block up the portal system. So what we see then is portal hypertension because of a blockage. Then we start to see splenomegaly, varices, and ascites come of it. Lab tests are going to include a positive stool sample that are positive for the schistosomiasis parasite. Treatment is usually going to be some sort of medication. And on ultrasound, there are a couple things that we're going to see. The first thing that we're going to see is, and most likely going to see, is fibrotic changes near the portal veins. So you're going to see kind of these little islands of echogenicity near the portal veins, and that's just fibrotic changes of the liver tissue around the portal veins. If there are enough eggs within the portal system, you might actually be able to see then echogenic material within the actual portal vein. So here we can see the liver with these islands, kind of polygonal islands around the portal veins. This is all fibrosis surrounding the portal veins. And then here we have, this one's kind of hard to see, the portal vein here, we can see more of that fibrosis around the edge of it. So that is kind of the hallmark sign of schistosomiasis that is moved to the liver. This one is also kind of hard to see. The harder the pictures are to come across, the more likely that we're not going to see these by ultrasound, but here we have the portal vein and we can see some echogenic material in it, most likely the eggs stuck within the portal vein system. All right, our next infectious disease then is hepatic candidiasis. Hepatic candidiasis is a fungal infection, and this is going to be caused by yeast in the body that affects organs. So you can have candidiasis of multiple organ systems. When it's in the liver, we call it hepatic candidiasis. Yeast is found all over the body. Some people can handle the yeast being there just fine. Some people don't handle it very well at all. And the people that don't tend to handle it very well are those that are immunocompromised. So we're going to see a higher propensity of hepatic candidiasis in patients who have AIDS or HIV, who possibly are going through chemotherapy or have had an organ transplant and are on suppressants. So anybody who's had their immune system depressed. Clinical signs are going to include the classical infection signs as well as abdominal pain. Lab tests are going to show increased LFTs when the hepatic candidiasis is found within the liver. Treatment for hepatic candidiasis is going to include antifungals and typically comes with a very good prognosis. On ultrasound, hepatic candidiasis actually has a very interesting appearance, but it's not specific to candidiasis, so we can only diagnose candidiasis by taking a biopsy of these lesions. So typically we'll see multiple small lesions, and they're going to have what we call a target or a bullseye appearance to them, where they have rings of hypoechoic and hyperechoic within the same lesion. If lesions hang around long enough, then they can start to calcify. So here is our first example of hepatic candidiasis. The arrows are pointing to a couple different lesions. Again, we can see kind of a darker, a brighter, and then a darker area, giving us kind of that target lesion appearance. The hepatic candidiasis are typically multiple, spread throughout the liver, and typically are going to have a little bit more of a rounder shape to them. Here's another example. Again, we can see darker and then brighter kind of target appearance to these, spread throughout the liver, multiple round structures. Here's another example of the hepatic candidiasis. So again, anything that looks like target appearance, bullseye appearance, multiple, with a history of immunocompromised, we need to think candidiasis. The problem with candidiasis is that, especially this one, reminds me of what some metastatic diseases to the liver appear like. So that is why we can't solely diagnose hepatic candidiasis just by appearance. Now this next couple slides cover a couple more infectious diseases that I want you to know about. Kind of just fit all the material into one picture of it. So this first one, pneumocystis carinii. This is basically pneumonia that spreads to the rest of the body and starts to affect organs. Pneumocystis carinii is important because it's the most common infection in immunocompromised patients. So pneumocystis carinii is the most common, but it's not something we see a whole lot by ultrasound, where hepatic candidiasis also affects immunocompromised patients, but we can see it by ultrasound much clearer. So pneumocystis carinii, when we do see it by ultrasound, actually takes on that starry night appearance. But we're going to combine that with the fact that the patient is immunocompromised and that they have had a recent pneumonia infection. Chronic granulomatous disease is also another one of those diseases where you really just kind of need to know what it is and how it affects the body. But again, it's pretty rare and most likely won't be seen by ultrasound. But chronic granulomatous disease is a disease where the white blood cells don't work properly. So if a patient gets sick, their white blood cells don't fight off the fungal infection. They don't fight off the bacterial infection. This is typically an inherited disease, and it's considered autosomal recessive. So remember that means there's a 25% chance of inheriting the disease. And we typically see it in younger boys. So what happens is that these children end up having lots of respiratory infections or other infections around the body, and the body just can't handle it. And then we start to see granulomas appear within the liver. So early granulomas are going to be more cystic appearing, and late granulomas become calcified. And so, if we have a patient that has chronic granulomatous disease and they're in their 20s maybe, they are probably more likely going to have some of these calcifications spread throughout the liver. So granulomas appear typically due to white blood cells kind of grouping together in an area. So granulomas are found all over the body. They can be in the lungs, in the spleen, in the liver, and they're just kind of these groups of macrophages or white blood cells that kind of group together during an infection process. And then they end up creating either these cystic spaces or kind of these weird little calcified spaces. So it's not uncommon to see those in many people, but it's the combination of granulomas on top of the inherited disease with the issue that your white blood cell count or your white blood cells aren't working the right way. That leads us to the diagnosis of chronic granulomatous disease. So I hope it makes sense that we really broke down a lot of these other diseases by symptoms and labs and all that, because we can really see and help the diagnosis with ultrasound, where both pneumocystic Carini and chronic granulomatous disease are a little less likely to be diagnosed by ultrasound and more likely to be something that we'll see incidentally, maybe for a different type of ultrasound, not so much to diagnose the disease. And that brings us to the end of infectious diseases. Hello and welcome back to another pathology lesson in which we've been looking at abdominal pathology. This lesson is going to cover the 5th part in the 5-part series of liver pathology, in which we are going to focus on malignant liver disease. We're going to begin with hepatocellular carcinoma. So the definition of hepatocellular carcinoma is primary cancer of the liver, quite often abbreviated down to HCC or referred to as a hepatoma. HCC is going to be more common in men and typically seen in patients that have a previous history of cirrhosis. Remember, NASH can lead to cirrhosis, which can lead to HCC. And remember that hepatitis or chronic hepatitis can lead to cirrhosis, which then can lead to HCC. Hepatocellular carcinoma is typically going to be asymptomatic until later stages, and it's going to present with classic cancer signs. So we're talking about fatigue, weight loss, night sweats, all of that. With HCC, because it is affecting the liver and the way that the hepatocytes function, we're going to see an increase in LFTs. But the thing that you need to know about hepatocellular carcinoma is that AFP will also be increased. AFP stands for alpha-fetoprotein and is typically found in pregnant women in the early stages of pregnancy. And that is because the liver of the fetus produces alpha-fetoprotein, and some of that gets into the mom's bloodstream. Totally normal for a pregnant woman to have a little bit of AFP. Not normal for a not pregnant woman to have AFP. Not normal for a male to have AFP. Not normal for a child to have AFP, increased levels. So anytime that we see AFP, we are going to be pretty sure that we are going to see some sort of hepatocellular carcinoma, some sort of cancer of the liver. As far as treatment and prognosis goes, hepatocellular carcinoma is typically diagnosed so late that it does not warrant treatment. And because of that, then it carries a pretty poor survival rate. Chemotherapy and surgery can be used if it's found early enough, or if they think they can prolong quality of life with those options. But it is so poor on the survival rate. At 5 years, less than 1% of people are still alive. So it has a very low survival rate. On ultrasound then, we are going to see typically a solitary hypoechoic mass. We might also see heterogeneous masses throughout the liver. And they might also take on a target bullseye appearance. So HCC does not have a one true and tried way of appearing on ultrasound. So again, any lesions that we see within the liver typically need to be biopsied to confirm a diagnosis. So here's one example of hepatocellular carcinoma. We have a rather large hyperechoic lesion within the right lobe of the liver. Here's another example of HCC in which we have a giant mass taking up a very good portion of the right lobe of the liver. You can see that it's very heterogeneous, kind of irregular walls, but taking up a good portion of that liver. Here, though, is another example of HCC in which we have this tiny little lesion. It actually almost looks like an adenoma. So hepatocellular carcinoma does not take on any one specific appearance. It needs to be biopsied, or it needs to have other imaging done to determine the diagnosis. Hepatic metastases are another thing that can pop up in the liver. Hepatic metastases then are secondary forms of cancer found in the liver from a separate primary source. So metastases occur when there is a primary cancer, say like in the lungs or of the skin, and it travels to another place like the liver. The most common form of primary cancers that we see are going to be colon. And then we also see it from the breast and the lung, but colon is the most common. And that makes sense for everything we talked about with infectious diseases. All that blood is shared from the gut to the liver. So it makes sense then that colon cancers are more likely to travel to the liver. What's the most important part, though, about hepatic metastases that you need to know is that hepatic metastases are the most cancer form in the liver. So if a patient is presented to you with, this patient has liver cancer, you need to immediately think they most likely have metastatic liver cancer versus hepatocellular carcinoma. Again, a patient presents with liver cancer, just cancer in the liver, that is most likely going to be metastases versus hepatocellular carcinoma. So hepatocellular carcinoma is the second most common type of cancer in the liver. Metastases are going to be the most common type. Clinically, these patients are going to again appear with classic cancer symptoms. They might have jaundice and ascites along with it. Typically going to show increased LFTs. Treatment is going to include chemotherapy and surgery. There's typically a better prognosis with less aggressive primary cancers. So if you have colon cancer or maybe some types of lung cancer, some types of breast cancer, those are going to be a little bit more, some of those are a little less aggressive. If those metastasize to the liver, you have a better prognosis. Compare that though to pancreatic cancer, which is very aggressive. Esophageal cancer, very aggressive. If those are their primary sources and those get to the liver, usually carries a very poor prognosis. On ultrasound, again, we are going to have multiple presentations. It all depends on what the primary cancer was. Different primary cancers usually present in different ways in the liver. Since hepatocellular carcinoma also doesn't typically present the same way every time, again, it's hard to diagnose the cancer based on just ultrasound images. You do need to biopsy these structures. So here is an example of hepatic metastases. Again, lots of lesions scattered throughout the liver. This actually carries a very similar appearance to hepatocellular carcinoma. Also kind of has a similar appearance to adenomas and a similar appearance to hepatic candidiasis. So there's lots of differential diagnoses that we could go with if we had no patient history. Here's another example of hepatic metastases. We can see kind of all these lesions, these bullseye lesions scattered throughout the liver. Here's another example of hepatic metastases. We can see the lesion here, and then we see kind of this anechoic structure in the middle here. I like to point this part out in the fact that cancers need a lot of blood to survive. And so they are usually relatively vascular. If we put color on them, that's why we can see color flowing through them. But if a lesion is not getting enough blood flow to it, it becomes necrotic. And so it's not uncommon to see kind of this necrotic center of especially larger lesions because it's not getting enough blood. That area necroses and then starts to liquefy. A couple more examples of metastases and some necrotic changes that are occurring. And then lastly, we have lymphoma. Lymphoma is a cancer of the lymphatic system that can affect other organs. Lymphoma will be touched on pretty much for every organ system that we talk about. How does lymphoma affect the liver, the spleen, the kidneys, all of it? And so for the liver, lymphoma is more commonly going to be affecting males, and typically there are some other immune issues present, maybe AIDS or a transplant. When lymphoma affects the liver, we're going to see hepatomegaly. We're going to see enlarged lymph nodes around the portohepatis, and then the patient's also going to have those classic cancer symptoms. The most important part that you need to pay attention to is how do the different types of lymphoma appear in the liver. So lymphoma comes in two types. It's Hodgkin's and non-Hodgkin's lymphoma. So Hodgkin's lymphoma is shown in this top picture here. It kind of makes the whole liver just look a little heterogeneous. So you can just see these kind of weird parenchymal changes scattered throughout the liver. That's Hodgkin's. Non-Hodgkin's lymphoma then shows up as target lesions. So you have the dark and the brighter area. So the way that I remember Hodgkin's versus non-Hodgkin's, I think of this non part, it's NON. So that makes a pattern kind of like the bullseyes do, dark, bright, dark. And dark, bright, and dark. So just try to come up with different ways that you can help yourself remember how some of these look on ultrasound. Again, with lymphoma, knowing that Hodgkin's causes parenchymal changes, non-Hodgkin's causes focal target lesions. And that is the end of the liver series and our malignant pathologies.